Hello everyone, my name is Awad Walied. I'm a second year med student, and alongside Asmaa Monsoor, who's a third year medical student, we will be giving you the Repro Basic Science Review PAL. Inshallah, we will go through quick review of all of anatomy and physiology for Repro. If you have any questions, feel free to message us. Here's our contact details. And without any delay, let's begin. This is a table of contents. Asma will cover pelvis 1 and 2 and female reproductive growth structure. I will do male reproductive system growth structure, perineum and external genitalia. This is anatomy. I will then go on to complete the male physio lectures, and Asma will finish it off with the female physio lectures.
All right, guys, pause here before we begin and let's make some small du'as and let's start. Okay, so the first lecture is pelvis. So in pelvis, what you need to know is that what is the pelvis made up of? It's made up of three big bones. We have the sacrum, the coccyx, and the pelvic bone. Now, the pelvic bone is divided into three bones. We have the ilium, which is the blue one, and then we have the pubis and we have the ischium. Now, the main thing that we need to know from the sacrum itself is we have the sacral promontory, which is this protruding thing, and then we have the ala, or the fan-like thing, and then we have these holes, which are the foramen. On the posterior side, we have these pointy structures, which are the spinous processes. Okay. Now, moving on to the hip bone itself. Now, the hip bone, as I said, is made up of the ilium, the ischium, and the pubis. Now, these three structures are joined together by the triradiate cartilage, which later makes them fuse as a single bone. Now, the structures related to the ilium itself, we have the iliac crest, and then we have the anterior superior iliac spine, and we have the anterior inferior iliac spine. On the posterior side, we have the posterior superior and the posterior inferior. Yeah, that's basically it. Now, for the ischium itself, we have this structure, which is the ischial tuberosity. Now, ischial tuberosity is where the entire body weight is projected when a person is sitting. And then we have the ischial spine, which is a pointy structure again, where many ligaments will attach, okay? And then we have the pubis. In the pubis, we have the pubic tubercle over here. And on the inner side of the pubis, which you cannot see over here, we have something called as the pectinate line. And on the inner side of the ilium, we have something called as the arcuate line, which I'll show you guys again in some time. Yes, that's basically it. Now, regarding the joints of the pelvic bone itself, we have two major joints. We have the sacroiliac joint over here, which is a synovial joint, and we have the pubic symphysis or the pubic joint over here, which is made up of a fibrocartilaginous joint. Now, moving on to the ligaments which stabilize these joints, we have five main ligaments that we need to know. Okay, so first we have the ligament between the ilium and the lumbar region, which is the iliolumbar ligament, and then we have the ligament between the sacrum and the ilium, which is the sacroiliac ligaments. Now, another ligament that is not shown in this picture is the ligament between the anterior superior iliac spine and the pubic tubercle, which is the inguinal ligament. Another two ligaments, we have the green one, which is over here between the sacrum and the pubic tubercle, which is the sacrotuberous ligament. Okay, and then, which is very important to know. And then we have the sacrum and to the ischial spine, which is the sacrospinous ligament. Now, these two ligaments make important foramen in the pelvic bone itself. And we have the, over here, we have the greater sciatic foramen, and we have over here the lesser sciatic foramen. So whatever's on top is the greater one, all right? And this is how the sacrotuberous ligament looks from the posterior side. Another thing that was mentioned in your slides was something called relaxin. So relaxin is basically a hormone that, again, um, makes all of these ligaments loosen and again allows for easier childbirth. Not really that important, but just thought of mentioning it. Okay, now moving on to the pelvic inlet and outlet. So this pink line is the pelvic inlet. Okay, and it's all made of bones. And first, let's see what the structures are. So we have the pubic tubercle or the pubic symphysis, and then we have the pectinate line. And then moving on, we have the arcuate line. And then we have the ala, and then we have the sacral promontory. And then it continues again. This is the pelvic inlet, and the pelvic outlet, compared to the pelvic inlet, also is made up of a ligament. Okay, so this ligament from the sacrum to the tubercle is tuberous part is the sacrotuberous ligament. So we have the coccyx, and then we have the sacrotuberous ligament, and then we have the ischiopubic rami. We have the tuberous, and then in the ischiopubic rami, and we have the pubic symphysis, the lower part of it. Not that important, but again, just know it. Now, what is the true pelvis? The true pelvis, or the greater pelvis, is the pelvic structures or everything, the space of the pelvis that is above the pelvic brim or the pelvic inlet. Whereas the that was the False pelvis, okay? Now, the true pelvis is the one that is below the pelvic brim or the pelvic inlet and has all of the reproductive organs and the anus and so on, okay? Now, what is the difference between the male and the female pelvis? Again, in females, the pelvis is designed to allow and facilitate childbirth. So everything in the pelvis is supposed to be bigger, and again, all of the holes and the entrance and the exits should be as big as possible. So how can we know this? From the inlet, males have heart-shaped inlet, whereas compared that to a female to have an oval-shaped inlet. The outlet is again narrow for the males and wider for the females. The ischial spine, the ischial tuberosity, all of this is inverted in males and everted in females. Everted means they're just trying to make more space. The pubic angle is narrower in males and wider in females, as expected. And again, so on. Not very important. Again, just if you know the idea, you'll get it, all right? Okay, now moving on to the pelvic muscle. So the pelvic cavity, imagine it as a bowel, okay? So we have the wall of the bowel and we have the floor of the bowel. What is the wall made up of? The wall is made up of two important muscles, and I'm telling you, this is super important for you to know. We have the obturator internus muscle, which comes from the inner part over here. Wait, let me real quick tell you what is the obturator foramen. Okay, so over here, as you can see, this hole is the obturator foramen. Okay, it's usually covered with a membrane called obturator membrane. Now, the obturator internus muscle starts from the inner part of the obturator membrane over here, and it moves into and goes through the lesser sciatic foramen. Okay, lesser sciatic foramen, very important to know. Compare that to another muscle, which is coming from the wall of the pelvis. We have the piriformis muscle, which comes from the inner part of the sacrum, then goes through the greater sciatic foramen, and then attaches to the femur. All right, so these are the two muscles making the wall of the pelvis. Now, what about the floor of the pelvis? The floor of the pelvis is made up of three important structures. We have the coccygeus muscle, the levator ani, and the pelvic fascia. Now, you can remember the elevator ani muscle is further divided into three muscles. Okay, we have the puborectalis muscle, which is over here, and it has two holes: the hole for the urethra and the vagina, and the hole for the rectum. Again, the puborectalis muscle is responsible for maintaining the anal tone and also making sure that the anus is properly fixed and pulled forward so that automatic defecation doesn't happen. All right. The other muscle in the levator ani series is the pubococcygeus muscle from the pubis to the coccyx. Okay. The third muscle is the iliococcygeus muscle. The iliococcygeus muscle comes from on top of the obturator internus muscle over here. So this is the iliococcygeus. This is the obturator internus. All right. It comes from the ilium part, and then it moves below. You cannot see over here to the and attaches to the coccyx. So iliococcygeus. So three muscles for the levator ani. How you can remember is with a silly mnemonic that Dr. Any has a puppy. Okay, puppy is PPI. Puborectalis, pubococcygeus, iliococcygeus. Now for the rest of the parts of the pelvic floor, we have the coccygeus muscle. The coccygeus muscle, as you guessed it, it should start from the coccyx and then it moves to the ischial spine. Okay, so this is the ischial spine from the coccyx. So the coccygeus muscle is between the spine and the coccyx. This is this. This is one more structure. And there's one more structure which is the fascia. Okay, the pelvic fascia. The pelvic fascia covers all of these muscles over here. It's also called as the parietal pelvic fascia because there's another fascia called as endopelvic fascia. And the endopelvic fascia, it was the one that covers the organs. I'll talk about that later. But for now, just know that the structures forming the pelvic floor is the the levator ani, which consists of the puborectalis, pubococcygeus, iliococcygeus, and then you have the coccygeus muscle, and we have the pelvic fascia. I remember this with the mnemonic again. I see three P's, which is the I means iliococcygeus, C is coccygeus, three P's are the puborectalis, pubococcygeus, and the pelvic fascia. Okay. Yes, one important thing that you need to know, and this has been coming in exams, is the innervation of these muscles. So all levator ani muscles and its constituents are innervated by the S3, S4 root or the pudendal nerve, okay? And whereas the coccygeus muscle is innervated by S4, S5, all right? And another minor thing that you need to know, again, Awad will talk about this later on, is that the line between, imaginary line between the two ischial tuberosities, again, divide the pelvic outlet into two parts. We have the urogenital triangle and we have the anal triangle. Kind of minor, but again, main thing that I want you to leave from this slide is S3, S4 pudendal nerve is the one that supplies the levator ani. All right. Okay, now moving on to the function of the pelvic floor muscles and the pelvic wall muscles. Again, they're responsible for holding the pelvic organs in, for facilitating childbirth, and also to make sure that there is no, again, leakage of urine or any feces. Okay, so if there's any problem to these muscles, what happens? This leads to organ prolapse, incontinence, or pain. Now, in order to exercise these muscles, we have something called Kegel exercise, and what the person does is that they exhale and they contract these muscles. Now, if they're trying to contract the muscles responsible for the anal tone by trying to hold in gas, now they're exercising the puborectalis muscle. But on the other hand, if they're trying to hold in urine, they're exercising the iliococcygeus muscle. All right, this is important for you to know. Okay, now moving on to the foramina. There are three main foraminas. As I mentioned before, we have the obturator membrane over here, and the obturator membrane leaves a small opening over here called as the obturator canal. Through the obturator canal, you have two things passing. We have the obturator nerve and the obturator artery and vein. Okay, then we have the greater and lesser sciatic foramina. This is the greater and this is the lesser. Through the greater sciatic foramina, we have this big muscle passing, which I mentioned before, which is the piriformis. About the piriformis, but still through the greater sciatic foramina, we have the superior gluteal artery and superior gluteal vein and superior gluteal nerve. Okay, everything that's on top is superior. Below the piriformis, we have the inferior gluteal artery, vein, nerve, and we also have the sciatic nerve, and we also have the pudendal nerve. Important for you to know. The pudendal nerve is exiting the pelvic cavity through the greater sciatic foramina. Now, through the lesser sciatic foramina, what are the things that enter? The things that are going to innervate or supply the perineum will enter now. So we have the internal pudendal artery, which exited through the greater sciatic, will also be entering the lesser sciatic now. And we have the pudendal nerve. And another thing is the obturator internus muscle, as I mentioned before. All right, so these are the structures. Now, quick question before we end the pelvis lecture. Okay, tell me, for example, there's a patient A, and they're coming you with urinary incontinence or urinary leakage. What is the muscle that is involved, that is weak, and what is the nerve that is damaged? Now, that is for urinary incontinence. What about fecal incontinence, which is, again, the feces are coming outside? Pause the video here, answer it on your own. All right. So the answer for urinary incontinence is that, as I mentioned before, in the Kegel exercise also, the urinary incontinence, the muscle responsible for holding in the urine is the iliococcygeus muscle. And iliococcygeus muscle is part of the levator ani series, and they're supplied by what? The S3, S4, or the pudendal nerve. Compare that to the fecal incontinence. Again, the feces are responsible or controlled by the puborectalis muscle. And if there's weakness in the puborectalis muscle, this leads to fecal incontinence, and again, it's supplied by the S3, S4, or the pudendal nerve. All right.
Now for lecture 2, which is male reproductive system, growth structure, first anatomy lecture by me. I want you guys to name these structures as I go along, okay? It's a recorded PAL, however, I still want you to name these structures as we go on. Anything covered by black is not something we're interested in. So now let's go over here. There's an oval structure which produces sperms, and it's also known as the testes. On top of it, you have the structure which has a head, a body, and a tail, and it's known as the epididymis. Connected to it, you have this tubular structure going all the way through the inguinal canal, looping around the bladder, and then joining with another duct. What is the name of the structure? You guys should know. It's the vas deferens. The vas deferens then joins with a duct from this structure, which is known as the seminal vesicle. And when they join up together, this duct, the joint duct, is now known as the ejaculatory duct. The ejaculatory duct then opens up into this structure, this tube, which is known as the prostatic urethra. Good job. Now, the urethra has 4 parts, and the first part is before the prostatic urethra. It's known as the pre-prostatic urethra. It's over here. Then you have the prostatic urethra going through the prostate. After that, this free urethra, you could think of it like that, is known as the membranous urethra. And then you have the penile urethra, the spongy urethra, which is very long. The beginning part is known as the bulbar portion of the spongy urethra, all the way over here. And then from here onwards, it's known as the penile portion of the spongy urethra. The prostatic urethra is the widest. The membranous urethra is the most delicate. The bulbar portion of the spongy urethra is more subjected to straddle injury, and the penile urethra part of the spongy urethra is the longest. Quick review: sperm is produced in the testes. Then we have the epididymis, head, body, and tail. Then the vas deferens goes all the way through the inguinal canal, joined with the duct from the seminal vesicle. The seminal vesicle produces 60% of semen. It's now known as the ejaculatory duct, which is the vas deferens plus the seminal vesicle duct. And then the ejaculatory duct opens up into the urethra, specifically the prostatic urethra. And 30% of semen is produced by the prostate and released into the prostatic urethra. Now let's talk about the descent of the testes. Something you should know is that the gonads develop in the abdomen across the posterior abdominal wall. By gonads, we mean either the testes or the ovary, okay? And the reason that they go down, the reason the testes goes down specifically to the scrotum, as you guys should know, is that it needs to escape the high body temperature because spermatogenesis cannot occur in the body, in the abdomen, because the body temperature is very high. And therefore, it goes down to a structure known as a scrotum, and the scrotum has a lower temperature by 3 degrees, which is what's needed for the testes to have spermatogenesis take place, okay? And the scrotum is basically a loose bag of skin. Now, the way it goes down is it's pulled, the testes is pulled by this green, it's colored green, however, it's not green in real life. This green structure known as the gubernaculum, it connects to the scrotum and the testes, and it pulls it all the way down. As you can see in the image, we also have the epididymis on top of the testes, and then this would be the vas deferens. On top of the testes, you have a peritoneum, the peritoneum covering it. Now, if we move on, you can see that a loop of peritoneum is moving down before the testes or with the testes. And this loop of peritoneum is known as the processus vaginalis, okay? The processus vaginalis is very important. I want you guys to remember it. It's basically a loop of peritoneum for now. And the testes goes down, gubernaculum is now shorter. We then move on, and over here you can see that processus vaginalis is more defined. It's a literal U, a loop of peritoneum. The testes is closer than ever to the scrotum. You have the epididymis and vas deferens. And finally, the processus vaginalis would bud off, you can think of it that way, from the peritoneum. The peritoneum will close off, the processus vaginalis would close off, and it's now known as the tunica vaginalis. The gubernaculum is now known as the scrotal ligament. The testes has successfully descended to the scrotum. And one more thing is that the tunica vaginalis, remember we said it's a loop of peritoneum. And since it's a loop, it has 2 layers. The inner layer is known as the visceral layer, the part closer to the testes. And the outer layer is known as the parietal layer, the part away from the testes. Now, if the peritoneum does not close off, this would lead to indirect inguinal hernias, okay? And 99% of hernias in babies are indirect inguinal hernias. If it partially closes off, some of the peritoneal fluid would go down into the testes, and this is known as hydrocele. One more thing we should mention is that if the testes does not descend and they remain in the abdomen, spermatogenesis will not take place, and this would lead to infertility because the male cannot produce sperm. Now, not only does the testes have to descend, but also the spermatic cord has to descend all the way from the abdomen. I summarize all of the spermatic cord contents into this orange line for illustrative purposes, okay? You guys should know the structures, by the way, they're very important. First structure is the vas deferens. Then we have the testicular artery, testicular veins, genital branch of genitofemoral nerve, and lymphatics. You guys should know these at least. So the journey is not simple. The spermatic cord contents have to go through 3 different layers, many layers, but Three different layers is all you should know. And as they go through a layer, they take a part of it and cover itself with it. So you can see it goes through this layer, takes some of the green, through this layer, some of the red, through this layer, some of the gray, and it forms this tube. Now, the first layer is known as the transversalis fascia, and it's once the spermatic cord takes covering of it, it turns into the internal spermatic fascia. So this will be the internal spermatic fascia, and this will be the transversalis fascia. The next layer is the internal oblique muscle, and the part which is taken by the spermatic cord is now known as the cremasteric fascia. And finally, the last layer is known as the external oblique aponeurosis, and the part which covers the spermatic cord is known as the external spermatic fascia. So going from outside to inside, the gray layer is the external spermatic fascia, red is the cremasteric fascia, green is the internal spermatic fascia, and the orange line is the spermatic cord contents, which are these. Now, the first entry through the transversalis fascia is now known as the deep inguinal ring, and the exit is known as, through the external oblique aponeurosis, is now known as the superficial inguinal ring. And you guys might recall this from your labs. This is now known as the inguinal canal. Okay. Now, what is the term used when the testes don't descend? 3, 2, 1. It's cryptorchidism. And we mentioned this before. If the testes don't descend and they remain up, spermatogenesis will not take place, and this would lead to infertility. Question time. Which of the following structures is not a part of the spermatic cord? A, B, C, D, E. You can pause. 3, 2, 1. The answer is D. All of them are part of the spermatic cord. However, the ilioinguinal nerve is not. The ilioinguinal nerve passes through the inguinal canal, but it's not part of the spermatic cord. This is a very high yield example, okay? Now, let's look at a transverse section of the testes and the scrotum, going from outside to inside. The first thing you're going to meet outside is the skin of the scrotum. Inner to that is something we're not concerned of, this black whatever. And then we have the tunica vaginalis, the parietal layer of the tunica vaginalis, and then the visceral layer of the tunica vaginalis. Inner to that, we have something known as the tunica albuginea, and albuginea is like Greek for white layer, I think, because it is white. Okay, in this image it's yellow, however, it's white. And then inner to that, you have this unlabeled red circle, because I added it manually, and it's known as the tunica vascularis, okay? The tunica vascularis is a blood vessel layer, and it's given off from the testicular artery. While we're at it, we can appreciate the testicular veins and the ductus deferens. Inner to that, you have the testes divided into different lobules. The lobules are the pink, different lobules, and the division is done by septa. And this is a septum over here. What else do we not mention? You also have convoluted seminiferous tubules inside the lobules, and this is where spermatogenesis takes place. After that, you have straight tubules. This is histology over here. And then you have the mediastinum of the testes, which contains the retitestes. And they then go through the efferent ducts into the epididymis. This is the head of the epididymis, and this is the sinus of the epididymis. We're going to look into it in the next image. I just want to mention that the testes has three covering. The testes specifically has the tunica vaginalis, the first layer, the outer layer. Then inner to that, the tunica albuginea. And inner to that, you have the tunica vascularis, the vascular layer. Now, this is a larger transverse section. As we mentioned before, you have tunica albuginea, and then tunica vascularis not shown over here. And then you have the testis divided into lobules by septa. In the septa, in the lobules, you have convoluted seminiferous tubules, which would produce the sperm, and the sperm will go through the retitestes in the mediastinum of the testes, and then they would go through the efferent ductules into the head of the epididymis, where the sperm would stay and mature. And it will take it around 20 days to mature in the epididymis, okay? After that, the sperm would move from the head of the epididymis to the body of the epididymis to the tail of the epididymis, all the way to the vas deferens or the ductus deferens. And in this image, we can appreciate the blood supply of the testes. We can see the testicular artery running along the vas deferens and the pampiniform plexus as well. The pampiniform plexus is the venous drainage of the testes. Testicular veins, they form the pampiniform plexus. Now, in case of vasectomy, you would ligate the proximal portion of the vas deferens and you would ligate the open ends, okay, the loose ends. And the result of a vasectomy is the ejaculate, not including sperm, okay? And this is a contraceptive method for males. Now let's talk about the blood supply and vein supply of the testes. Since the testes descends from the abdomen, it's natural for us to assume the blood supply is going to be all the way from the abdomen. And so we can appreciate the right testicular artery and the left testicular artery over here, going all the way through the inguinal canal to the testes, and their level is L2. This is very important, okay? Arterial supply, L2. As for the venous drainage or venous supply, the testicular arteries would form the testicular veins, would form the pampiniform plexus, and then you'd have the right testicular vein draining into the inferior vena cava. However, the left testicular vein is different because it drains into the left renal vein. And in case of obstruction of the nerves, of the veins, I mean, mainly the left testicular vein, you would have blood pooling in the pampiniform plexus over here, and this is known as varicocele, okay? Patients with varicocele would present with testes which feel like bag of worms, okay? This is very, very high yield, bag of worms, very high yield. And since when the blood pools up in the testes, this would heat up the testes, and remember, we said the testes are not good with heat, therefore spermatogenesis will not occur, and this could lead to infertility. Now for the lymphatics of the testes and the scrotum. Remember, blood supply, lymphatics, all of that, it's relevant and related to the origin of the structure. The testes, as we said, developed in the abdomen. However, the scrotum has always been down. So the scrotum, lymphatic drainage would be to the superficial inguinal lymph nodes, all the way down. However, the testes would drain into the para-aortic lymph nodes. And generally, you should know this by now, lymphatics are a way that cancers can spread. And therefore, testicular cancer can spread through this route to the para-aortic lymph nodes, okay? Something which I don't know where to add, honestly, which is testicular torsion. Testicular torsion is a very serious emergency, and it happens when the spermatic cord twists. And this may lead to blocking of the blood supply to the testes, and you can imagine what's going to happen if this remains. Testes would lose the blood supply, and they would end up dying, and that's why it's a very serious emergency. Now let's talk about the prostate and its capsule. The prostate is a part 3 glandular and part 3 fibromuscular gland. It's located below the bladder and above the urogenital diaphragm. It contributes about 30% of seminal fluid, and lymphatic drainage is to the internal iliac lymph nodes. The relations of the prostate are anterior relation. It lies posterior to the pubic symphysis. Posterior relation, it is located anterior to the rectum. Lateral relation, it's located medial to the levator ani muscles. This is an image of a prostate with an adenoma, which simply means a cancer. And something we should know about the capsule of the prostate is you have a true capsule all the time. And in case of adenoma of the prostate, we would have something known as a false capsule, which is basically the prostate cells compressed so much to the point that they form a capsule, okay? Now, all you need to know from this is that between the false capsule and the true capsule, you have the prostatic venous plexus. And the prostatic venous plexus is connected to the vertebral venous plexus all the way near the vertebra. And the clinical significance of this is that in prostate cancer, the cancer can travel through this route. It can travel through the prostatic venous plexus all the way to the vertebral venous plexus, and the patient or patients would complain of backache, okay? Backache because of the vertebra. And something which is not very relevant is that this cancer spreads through the blood and not lymph. Most of the cancers we're going to talk about in your med school journey, they're going to spread through lymphatics. However, this spreads through the blood route, okay? Now let's talk about the zonal anatomy of the prostate. We can divide the prostate into zones and into lobes. However, the doctor did not talk about lobes at all. He just mentioned zones. I will still mention that transitional zone could also be known as the median lobe, okay? Transitional zone, median lobe. Not exactly, however, just keep it like that. Anyways, the transitional zone makes up around 5% of the prostate and it surrounds the urethra. The central zone makes up around 25% of the prostate and it surrounds the ejaculatory duct. Then you have the peripheral zone, the purple over here, and it looks small in this image. However, it covers everything. That's why it's not shown in this transverse section. It covers everything. It covers the transitional zone, the central zone, and the lower part of the prostatic urethra. And finally, you have the anterior or fibromuscular zone over here, not very relevant for us. What's important though is that the transitional zone is hypertrophied in benign prostatic hyperplasia. And the peripheral zone is the zone where most prostate cancers occur. And it's also the only zone which is felt through digital rectal examination. And when it's felt as hard and nodular in the case of prostatic cancer. You're gonna get like 3 questions from this. So if you don't understand it, just memorize it. I'll give you guys like 3 seconds to look into it. Now let's talk about benign prostatic hyperplasia. BPH generally causes lower urinary tract symptoms, and not all of them would be present in every patient. However, most of them will be. The cause would be in blue and the effect would be in red. The median lobe or the transitional zone of the prostate in benign prostatic hyperplasia would protrude into the bladder. This is a normal prostate and this is a prostate with BPH. This is the transitional zone and it would protrude into the bladder, okay? This would lead to buildup of urine behind the protrusion. So this is a protrusion, urine would build up over here. And this urine would continuously stimulate the prostate, and this would lead to urgency, frequency, and nocturia. Number 2, the internal urethral sphincter would malfunction as well. And this would lead to urine leak and retrograde ejaculation. Retrograde ejaculation simply means the ejaculate would not, this is the ejaculatory duct, the ejaculate would move back into the bladder. And then we have the median. Another cause is that the median lobe would compress the prostatic urethra. This is a normal and wide prostatic urethra. In a patient with BPH, it's very compressed. And when it becomes narrow, the patient would spend long time peeing. Okay.
All right, let's move on to the third lecture, which is the female reproductive system. So, getting an overview, we have the uterus over here. Now, the uterus has the fundus, which is the top part, and we have the body, and we have the cervix. Okay, and then we have the vagina. Now, the uterus has three main layers. We have the endometrium, myometrium, and we have the perimetrium. From the vagina to the cervix, we have some spaces both in the anterior, posterior, and lateral sides, which are called the fornices. Okay. Now, the blood supply of the endometrium itself comes from the sorry, not for the endometrium, I meant the uterus itself comes from the uterine artery, and this uterine artery comes from the internal iliac artery. That's basically it. Now, the main thing that I want you to know is the angles of uterus position. Okay, so the angle between the vagina and the cervix. Okay, it's called as the angle of anteversion. So V for vagina, V for eversion, anteversion, and so on. It's usually 90 degrees. And then there's another angle between the cervix and the body of the uterus. Okay, and this angle is called as angle of anteflexion. So normally both are anteflexion, anteversion. Okay, and this is how it rests on top of the bladder. But in cases of any, maybe it could be normal positional changes, or it could be abnormal ligaments or muscles getting weak, then the uterus can change its position. Now, what are the positions that it can change? So normally we have the anteversion and the anteflexion. If the angle between the cervix and the body is lost or becomes bad or abnormal, you call this as retroflexion. So normal is anti, problem is retro. So this is retroflexion, but still anti-version. What if the angle between the vagina and the cervix is abnormal? Then this is called retroversion. V for vagina, V for version. Okay, and then but still this is normal, so we call this as anti-flexion. What if both are abnormal? Then this is called retroversion, retroflexion. And again, this type of position of the uterus is most associated with infertility. Whatever I've said is written over here, so it's no worries. Now, moving on to pouches. So the peritoneum itself drapes on top of the pelvic organs and makes certain anatomical pouches or spaces, all right? So the pouch between, or the space between the rectum and the uterus is called the rectouterine pouch, also called this pouch of Douglas. Okay. Now, this pouch of Douglas is the place where most blood or any infection or in liquid that happens in the peritoneal cavity or in the pelvic cavity comes and stands or gets stagnated in or pools in this space. All right. Now, if I want to drain or if I want to test for any of the fluid that's stuck over here, how do I do it? I go through the posterior fornix and then I drain through this pouch, okay, which is the pouch of Douglas or rectouterine pouch. Now, the other part, which is anteriorly, we have the vesicouterine pouch. Vesico means the bladder and the uterus, okay? Yeah, this is another pouch. So these are two pouches. But what I want you to know is that through the posterior fornix, you can reach the pouch of Douglas, all right? Now, moving on to the other parts of the female reproductive system, we have the cervix now. In the outer part of the cervix, it's called as exocervix, and there's a hole, and this hole is called as the external orifice, okay, or external os. And then you enter and you have the cervical canal, and then you enter through inside the uterus through the internal os. And the inside part of the cervix is called as endocervix, all right? And then we have the fallopian tube. The fallopian tube has different parts. We have the isthmus, which is the most narrowest part, and then we have the ampulla, where fertilization takes place. And then we have infundibulum, which is the widest part. And then we have the fimbriae, which are the finger-like projections, which collect the egg from the ovary. And the ovary makes eggs, all right? Yeah, that's basically it for over here. Again, you can pause and read all of the other structures if you like. But I just noted down the major parts. Oh, one more thing regarding the ovaries themselves and the fallopian tube. As I mentioned, the peritoneum again covers all of these structures, right? The peritoneal covering, just know this for now. The peritoneal covering near the fallopian tube is called mesosalpinx, and the peritoneal covering close to the ovary is mesovarium, all right? Now, the blood supply for the ovaries themselves do not come from the uterine artery. They come from another artery called as the ovarian artery, okay, or the ovarian vessel that you can see over here. And these blood and then the vein or the venous supply from the ovaries themselves return back and enter into the inferior vena cava. But for example, not for example, but the vessels or the venous plexus, venous drainage from the left ovarian ovary does not go directly into the inferior vena cava. It goes to the left renal vein, and then from the left renal vein, it goes into the inferior vena cava. All right, just know this. Okay. Whatever I've written is what I said. Okay, now moving on to the most important part of the lecture, which is all the ligaments and structures that make the uterus and all of the vagina and everything in place in the pelvic cavity. So as you can see, the lungs usually are trapped or kept in place by the ribs. But what about the pelvic structures? Now, the pelvic structures have a ton of ligaments and stuff that we're talking about, inshallah. And it's very important to know for us because some of these ligaments, from the places that they attach to the places that they go and fix themselves to, these can be passageways for cancer, and for blood vessels, for lymph, and so on. Okay, so this is the cervix, this is the body, this is the fallopian tube, and this is the ovary. Hopefully, my diagram makes sense. Now, the first layer of covering and also ligaments that we have is the endopelvic fascia. Now, I mentioned before we have the parietal pelvic fascia, which covers the muscles. Now, the endopelvic fascia covers the organs. Now, in certain places, this endopelvic fascia thickens, again, to provide support. There are many parts. The three important parts that I want you to know are these three. First, we have the fascia thickening near the cervix, and then it attaches to the lateral wall of the pelvis. This is called as the transverse cervical or cardinal or McIntyre's ligament. Okay, so this ligament is the one that fixes the cervix to the pelvis. Okay, now what is important regarding the cardinal ligament is that in the cardinal ligament it has the uterine arteries. So the uterine arteries first traverse through the cardinal ligament and then they supply the uterus, all right? So if there isn't any injury to the cardinal ligament, what happens is that there's an injury to the uterine arteries themselves. That's one thing. The second ligament, what I want you to know, is the uterosacral ligament. Uterosacral ligament, again, connects the cervix to the sacrum. Okay, so practically keeps it stabilized from the backside. Now, one important thing that I want you to remember regarding the uterosacral ligament is that if this ligament becomes weak, then the cervix is no longer stabilized. So the angle between the cervix and the vagina is lost. And what is the name of this angle? Usually it is called as anteversion. All right. So if there is an issue with uterosacral ligament, this leads to retroversion. All right. And another ligament is the pubocervical ligament. Again, it connects the cervix to the pubis. There are many other ligaments and thickenings of endopelvic fascia. You don't need to know all of that. Now, moving on to the second layer. The second layer of ligaments and supporting structures is from the peritoneum itself. So as we mentioned before, the peritoneum drapes around all of the pelvic organs. Now, when they drape around all the pelvic organs, they form double layers. So broad ligament, which is the name for all of this, is actually a double peritoneal layer, all right? Double peritoneal layer. Now, broad ligament, depending on where it is situated, has a particular name. Now, if it's near the fallopian tube, it's called as mesosalpinx, as you can see over here. If it's close to the ovary, it's called mesovarium. And if it's near the uterus, it's called mesometrium, all right? And then this broad ligament, again, connects to the lateral side of the pelvic wall. Now, what is important for us to know is, all right, but anyways, before that, again, this is the mesosalpinx, the double layer of peritoneum, not the one that is covering the fallopian tube. No, we're talking about broad ligament, which is a double peritoneal layer. So this double layer, this is called mesosalpinx, this double layer is called mesovarium, and this double layer is called mesometrium, and together they're called as broad ligament. Okay, is that it? Yes, that's it. Now moving on to the last few ligaments, we have the ovarian ligament. Now, the ovarian ligament is the one that connects the uterine horn to the ovary and makes the ovary stable. Okay. And then we have the suspensory ligament, which is over here, which is also called as the infundibulopelvic ligament. Okay, just a fancy name. Now, the suspensory ligament connects the ovary to the lateral pelvic wall, and it has some important structures, which is the ovarian vessels, nerves, and lymphs. So everything and anything that supplies the ovary comes through the suspensory ligament or the infundibulopelvic ligament. All right. And then we have the round ligament. The round ligament connects the uterine horn to the labia majora. So what happens is that this connection pulls the uterine body forward or bends it. Okay, and so this ligament is the one that is responsible for making the angle of anti-flexion. So if there's a weakness in round ligament, what do you think will happen? Exactly. So there will be retroflexion. All right. Another important thing that I want to mention is that the round ligament and the ovarian ligament are derivatives of the embryological structure, which is gubernaculum. All right. Okay, so again, to summarize, which is very important, guys, many questions come from this part. We have the infundibulopelvic ligament, which is also called as the suspensory ligament. Now, what does it connect? It connects the ovary to the lateral pelvic walls. What does it have? It has the ovarian vessels, okay? Then we have the ovarian ligament, which connects the uterus to the ovary. Again, this is a derivative of the gubernaculum. And then we have the round ligament. The round ligament connects the uterus to the labia majora. It is also a derivative of gubernaculum, and it travels through the inguinal canal. Then we have the broad ligament. Now, the broad ligament has three parts. We have the mesometrium, mesovarium, and mesosalpinx. Okay, it is nothing but a double peritoneal layer. It connects again the uterus to the lateral pelvic wall, and it has three important structures. So I did not mention this before. So listen carefully. What are the structures inside the broad ligament themselves? The structures inside the broad ligament are three. We have the ovary, the fallopian tube, and the round ligament. Okay, you can remember that's rough if you want. Okay, so what is inside the broad ligament? You have the round ligament, ovary, and fallopian tube. Then you have the cardinal ligament, which is again a thickening of the endopelvic fascia. It connects the cervix to the lateral pelvic wall. What it has is very important to know is the uterine vessels. Okay, so if there's any problem with the uterine vessels over here, for example, during surgery, if someone wants to do something and then they by mistake ligate the uterine vessels over here instead of, for example, the urethra, because urethra is closer to the uterine vessels, then this can lead to problems to the uterus. Okay, so again, very important to know is again the uterine vessels inside the cardinal ligament. And then we have the uterosacral ligament, which connects the cervix to the sacrum. Again, if there's a problem to this leads to retroversion. All right. Okay, whatever I said is also written over here. Now, you can use this slide again to just revise all of the ligaments that I mentioned on your own, just like an active recall. Now, moving on to the blood supply of the pelvis. Now, the pelvis themselves is supplied by the internal iliac artery. So we have the abdominal aorta that divides into the common iliac arteries and the external iliac and the internal iliac. Now, from the internal iliac, some of the main important branches that I want you to remember is the superior gluteal artery that goes through the greater sciatic foramen about the piriformis, and we have the inferior gluteal artery that goes through the greater sciatic foramen but below the piriformis. And then we have the internal pudendal artery. The internal pudendal artery, very important for you to remember, is that it goes from the greater sciatic and then enters back in through the lesser sciatic. Okay, and then we have the uterine artery as well, and then one more artery is the obturator artery, again that goes through the obturator canal. Now the uterine artery again supplies the uterus, and it comes from the internal iliac artery. Compare that to the ovarian artery. The ovarian artery comes from the abdominal aorta directly. All right. So these arteries again anastomose and make some collateral connections over here, which again helps in a better blood supply. Just what I want you to remember is ovarian from abdominal, uterine from internal iliac. All right. Moving on to another important concept is lymph drainage. Okay. So just don't mind my weird drawing over here, but hope it helps. Okay, so for the fundus of the uterus, the most of the fallopian tube and the ovary, all of this drain into para-aortic or pre-aortic lymph nodes. Since all of these are at top, that means they're getting A grades, all right, and so they're supposed to be drained by the para-aortic lymph nodes. Okay, and then we have the body of the uterus themselves, okay, which is draining into the external iliac lymph nodes. And then we have the cervix. Part of it is draining into the external iliac, and part of it is draining into the internal iliac and sacral lymph nodes. Now, the important thing is the vagina and the isthmus of the fallopian tube. These two structures are drained by into the superficial inguinal lymph nodes. Now, how does the superficial inguinal, how does the lymph from the isthmus enter into the superficial inguinal lymph nodes? Is through the round ligaments. As I mentioned before, all these ligaments are again passageways of both blood, veins, venous arteries, veins, and also the lymph structures. All right. Now, regarding the veins, not veins, regarding the nerves of the pelvis, important nerves is the sciatic nerve. Again, it goes through the greater sciatic foramen. If there's a hypertrophy or problems to the piriformis muscle, this leads to affected sciatic nerve. And then we have the pudendal nerve. Now, the pudendal nerve is important for us to know. It comes from the lumbar and sacral regions, or the roots, and then it goes close to the ischial spine over here, ischial spine, and then it enters through the pudendal canal, and then it supplies the perineum. All right. So that was the pudendal nerve. Then we have another nerve, which is the obturator nerve. So this was the general nerve supply of the pelvis. But what about the uterus? Now, the uterus, we have the sympathetic nerve supply that is coming from the T10 to L2 roots. So we know that sympathetic is coming from T10 to L2, right? So it's easy. And parasympathetic is from the S2 to S4. Now, the viscerosensory or the pain sensations of the uterus divide into two parts. The uterus body and the fundus is coming from the T10 to L2 because, again, that part of the uterus is just a bit more superior. And we have the cervix. The pain for cervix comes from the S2 to S4. So this is important for you to know, okay? The pain sensations. Now, more clinical, just to sum up all of the clinical stuff from this lecture. So, tubal ligation is when we ligate the fallopian tube. Again, this is a form of contraception. Then we have ectopic pregnancy, is where pregnancy or the zygote goes and attaches somewhere else, and not in the endometrium. And the most common place that it gets stuck is the tubal part, okay, and starts growing over there. Then we have the problems with the pelvic floor itself. If there's a problem with the pelvic floor and the urinary bladder is protruding out, it's called cystocele. If the anus is protruding out, it's called rectocele. And if the urethra is protruding out, it's called this urethrocoele. What happens if the uterus is protruding out? It's called uterine prolapse. There are 3 degrees depending on how again, how severe it is. Now, what is prosidential? Prosidential, just keep this at the back of your head. That is, it's when both the uterus, the urinary bladder, and the rectum all prolapse, all just come down because of the weak pelvis. Then we have the ureter that can be mistakenly ligated. Now, as I mentioned before, the ureter and the uterine arteries are really, really close together, lie close together, close to each other near the transverse cervical ligament. So anytime you want someone's having maybe a uterus surgery or maybe a ureter surgery, these can be mistakenly ligated or tied up, which can lead to complications. Okay, and then we talked about, yeah. Now moving on to the nerve blocks in pregnancy. So sometimes pregnancy can be really painful, and you might want to block some of the pain sensations through the visceral sensory pathways. Okay, this can be done in 3 different levels. First is at the lumbar level. This is called spinal block. Again, it blocks pain sensations from everything waist down, including the legs. Okay, this is the most what you can see comprehensive sort of pain block. And then you have the caudal block, which blocks the pain from everything inside the pelvic cavity. And then we have the pudendal block. The pudendal block blocks only and only the pudendal nerve. Now, where's the pudendal nerve? As we said, the pudendal nerve is near the ischial spine. So the doctors palpate the ischial spine, use it as a landmark, insert the injection near that, and the pudendal nerve is blocked. Why this is done is, again, to do episiotomy. Episiotomy is when you want to cut some of the pelvic floor muscles in order to facilitate childbirth. So this is called midline episiotomy, and this is mediolateral episiotomy. Now, midline episiotomy, again, there is a risk for damaging the anal sphincter as well over here. And also, when you cut directly over here, the perineal body is the one that is also cut. Okay. Again, Awad will talk about this more.
Now for lecture 4, perineum and external genitalia. Something to keep in mind, guys, is that if you really want to understand the perineum, you can watch a lot of YouTube videos on it, and you can watch the lecture as well. I will go through the high yield points, and I will basically give a quick overview of perineum and external genitalia, and I will mention the very high yield points, which are most likely going to come in your exam. So the perineum is the area between the anus and the scrotum, or the vulva. And the way we look into the perineum of a patient is through this. We would have the patient lie in this position. It's known as the lithotomy position. And if we look at the patient from here, like into here, from here into here, we would see this. And one thing we can appreciate is that we have 2 triangles. The urogenital triangle, which contains the urinary and the genital, and the anal triangle, which contains the anus. This is another image of the perineum, and in this image, we can appreciate the borders more. The borders are very important for the urogenital triangle, not as much for the anal triangle. So the anterior border of the urogenital triangle is the pubic symphysis. The lateral borders, this and this, of the urogenital triangle are the ischiopubic rami. And finally, okay, not finally, but the posterior border of the urogenital triangle is the imaginary line between this ischial tuberosity and this ischial tuberosity. And then this is in 2D. If we look at it in 3D, you would have a roof, which is deep, and a floor, which is more superficial. The roof is formed from the levator ani muscles, and the superficial floor is formed by the perineal membrane. These are the borders, very important to know. Now, the perineum itself is divided into the deep pouch and the superficial pouch. Let's look at the contents in males and after that in females. The contents in males are the deep transverse perineal muscle, the perineal membrane, the external urethral sphincter, the urethra, the bulbourethral glands, and the dorsal neurovascular structures of the penis. Between the deep pouch and the superficial pouch, for both males and females, you're going to find a perineal body. Now, for the contents of the superficial pouch, you have the ischiocavernosus and the bulbospongiosus. You also have the bulbous part of the spongy urethra. You also have the superficial transverse perineal muscle. And finally, you have the deep perineal branches of the internal pudendal vessels and nerves. Now, for the contents of the deep pouch in females, they're simpler, I think. You have the perineal membrane, external urethral sphincter, and the urethra. You also have the dorsal neurovascular structures of the clitoris. Again, perineal body in between the deep pouch and the superficial pouch. And the contents of the superficial pouch in females are the clitoris, the ischiocavernosus, and the bulbospongiosus. You also have the greater vestibular glands, the superficial transverse perineal muscle, and finally, the deep perineal branches of the internal pudendal vessels and nerves. This is basically all you need to know for perineum. However, I will give you guys like 2 seconds to read it on your own. You can pause it to recording. Anyways, we didn't say anything about the perineal body, however, it's very important. And the reason it's important is because it's a location where you have many muscles running through it, okay? And if the perineal body gets damaged in males and in females, the perineum itself would lose its structure. Some of the muscles running into the perineal body are number one, external anal sphincter, number two, levator ani muscles, number three, bulbospongiosus, number four, superficial transverse perineal muscles, and finally, deep transverse perineal muscles. And I guess that is it. Let's talk about the ischial-anal or the ischiorectal fossa. The ischial-anal fossa is a pair of fat-filled spaces located in the anal triangle. And the boundaries of the ischial-anal fossa, again, boundaries of the ischial-anal, not boundaries of the anal triangle. Anal triangle boundaries are not that important, okay? The boundaries of the ischial-anal fossa are superiorly, you have the levator ani, laterally, you have the obturator internus, and medially, you have the anal rectal junction. Now let's look at a case. This is somewhat mentioned in perineum and external genitalia both. If we have a rupture of the bulbous part of the spongy urethra, now, can you guys remember what happens most commonly with the bulbous part of the spongy urethra? We mentioned this in the first lecture of male. The answer is straddle injuries. By straddle injuries, we mean maybe the doctor gave this example where a man steps into a manhole and then he remains hanging, or bike race, whatever. Anyway, straddle injury. If the bulbous part of the spongy urethra ruptures, you would have superficial extravasation of urine. And the location of the extravasation of urine is the superficial perineal pouch, particularly between the perineal membrane and Colles fascia, or between the deep fascia and Scarpus fascia. Now, one thing I didn't mention is that the deep perineal membrane, wait, let's go back. The deep perineal pouch, is in between what's it called? Is in between the urogenital diaphragm over here and the perineal membrane. Okay? As for the superficial pouch, it's in between the perineal membrane and Colles fascia. So in this case, where we have extravasation in the superficial perineal pouch is going to be between the perineal membrane and Colles fascia, or between the deep fascia and Scarpus fascia in a different location. Now we can appreciate the superficial extravasation in this diagram. As for the deep extravasation of urine, it occurs when there is rupture of the membranous part of the urethra, which is the most delicate part of the urethra, and the location of extravasation is above the urogenital diaphragm, over here. Now, this is a list of male and female structures in external genitalia. Something I really want you guys to remember is that the greater vestibular or Bartholin's gland is found in the superficial perineal pouch. However, its male counterpart, which is known as the bulbourethral gland or Cowper's gland, is found in the deep perineal pouch. That's the difference between male and female. Okay? We will finish all of the male physio lectures in one go, inshallah, starting with physiology of the male reproductive system. Now, this PAL has been recorded before you guys took your review session. Yani I hope you guys have a review session by Dr. AJR. In the event that you do take a review session, I heavily recommend that you study whatever he says because he will deliver, okay? But this is not oriented on the review session. Now let's begin. So the most important thing that I want you to remember is that female is default. Now let's start with the sex determination process. Before 6 weeks, we cannot tell the gender of the fetus physically. However, after 6 weeks, we can because the gonads develop into either a testis or an ovary. The process by which the gonad develops into a testis is through this SRY gene. Now, the Y chromosome contains a gene known as the SRY gene, or the testis determining factor. And when a fetus has the Y chromosome, they would express the SRY gene. And when the SRY gene is positive, the gonad would develop into a testis. Okay? In the event that the SRY gene is not there, which is either in XX, normal female, or X0, a missing sex chromosome, we would have SRY negative conditions, and the gonad would develop to the ovary because female is default. After that, the testis would produce anti-Mullerian hormone, specifically the Sertoli cells would produce anti-Mullerian hormone, and this anti-Mullerian hormone will prevent the proliferation of the Mullerian duct, and therefore we would not have female internal duct system. Okay? On the other hand, the Leydig cells would produce testosterone, and this testosterone would lead to the proliferation of the Wolffian duct, which would lead to the formation of the male internal duct system. And some parts of the male internal duct system are the vas deferens, the epididymis, and the seminal vesicles. Okay? Now, if we don't have anti-Mullerian hormone, which is produced by the Sertoli cells, we would have proliferation of the Mullerian duct, and this happens with females. And so the Mullerian duct would develop into the uterus, fallopian tube, and the upper vagina. Now, the testosterone, which is secreted by the testis, would then be changed into DHT, which is a stronger version of testosterone, by an enzyme known as 5-alpha reductase. Remember this enzyme very well. Now, this DHT would act on the genital tubercle, the urogenital folds, the labioscrotal swellings, and the vaginal cord to give us the external genitalia, specifically the male external genitalia, which is the penis, the penile urethra, and the scrotum. In the event that we don't have DHT, which would be the female conditions, the ovary would produce estradiol, and the estradiol would lead to the formation of these structures, okay, the female external genitalia. Now, quickly, let's recap. The male internal duct is triggered by testosterone over here. The female internal duct is triggered by the absence of AMH. That's the difference, because female is default. The male external genitalia is triggered by DHT, and the female external genitalia is triggered by estradiol, which is an estrogen. Estradiol, okay? Now, in the embryo, Sertoli cells produce AMH, and Leydig cells produce testosterone. However, in like a grown-up, Sertoli cells would not produce AMH. They would instead be involved with spermatogenesis, and Leydig cells will still continue to produce testosterone. Okay. And lastly, Sertoli cells are sensitive to temperature, unlike Leydig cells. And this is clinically relevant in the context of crypt or orchidism. Okay. Think about it. If the testes does not descend, Sertoli cells would be affected by the high temperature, and Sertoli cells would not produce anti-Mullerian hormone. Okay? So there would be absence of anti-Mullerian hormone, and we would have development of the female internal duct system. Something to think about. Unlike Leydig cells are not affected by temperature, and therefore they would still produce testosterone regardless of the body temperature. Okay? Now, the testes has two functions. The first one is spermatogenesis, which is done by Sertoli cells. The next one is steroidogenesis, which is done by Leydig cells. And the testes also has three ways by which, not the testes, but the male external genitalia, has three ways by which it controls temperature. Number one, Dartos muscle contracts and wrinkles the scrotal skin to retain heat. Number two, cremaster muscle contracts and elevates the testes to retain heat. Number three, pampiniform plexus picks up heat from testicular artery and it moves away this heat from the testis. Now, if there's a thermoregulatory dysfunction, we may have sterility or infertility due to the lack of spermatogenesis. Now let's look at the cross section of a seminiferous tubule. First of all, we have the Leydig cells over here located on the outside and under the basement membrane. On top of that, we have the basement membrane. On top of that, we have Sertoli cells, which are over here. And they line up all the way across the basement membrane. And next to them, we have germinal cells going all the way from the basement membrane, lining up on top of each other till the lumen. And one thing to note is that the Sertoli cells are extending all the way from the basal lamina or the basement membrane till the lumen. There is no separation. Now, there is something important which is not shown in this image, which is the presence of tight junctions. Now, Sertoli cells next to each other would have a tight junction. Let's just imagine that it's here. We will look at an image with the tight junction later. So, usually there would be a tight junction between each Sertoli cell, and this will completely separate the blood from the sperm. And this would create something known as the blood testes barrier. I would write it as BTB in the PAL, okay? This blood testes barrier prevents exchange of molecules between this compartment and this compartment. Now, if we said that the tight junction was over here exactly, anything from this tight junction to the outside, look at my pointer, from this tight junction to the outside is known as the basal compartment. Okay? Basal compartment. Anything from this tight junction to the inside is known as the adluminal compartment. Remember it, tight junction to the lumen, adluminal, tight junction. Outside, basal. All right? And finally, the purpose of this tight junction all around is to prevent an immune reaction forming against the sperms, because the sperm proteins are not recognized by our body as self proteins. On the other hand, they're recognized as foreign, and so the body would try to attack it. And if the blood testis barrier is not present, we would end up killing our sperms. Some other definitions, quite important, so please focus. Spermatogenesis is the entire process of making a sperm. Goes all the way from spermatogonia until we have a mature spermatozoa or a mature sperm. And the length of this process is 64 to 72 days. Remember this number, 72 days. 52 of those days are spent in the seminiferous tubules, and the other 20 days are spent in the epididymis, where the non-motile sperm gains motility. The next definition is spermiation. Spermiation is the release of mature spermatids into the lumen of the seminiferous tubules by the Sertoli cells. And the way they do that is they release some fluid to push the sperms into the lumen. And finally, we have spermiogenesis. So we had spermatogenesis, spermiation, now spermiogenesis. Spermiogenesis is the conversion of round spermatid to a sperm-looking spermatid. Round spermatid to a sperm-looking spermatid. And we will talk more about them in the spermatogenesis lecture. Now let's look at the molecular mechanism of Sertoli and Leydig cells. First of all, LH binds to Leydig cells. Link it, okay? Link it. LH binds to Leydig cells. L with L. And when the LH binds to the Leydig cells, this would trigger the formation of testosterone through cholesterol. So we would have LH binding, cholesterol form would change into pregnenolone, pregnenolone would change into testosterone. You guys should know this pathway from endocrine. Testosterone would then move through the blood testis barrier into the Sertoli cells, okay? So the reason testosterone is allowed to pass through the barriers and through the blood vessels and everything is because it's a steroid. You guys should remember this from which lecture was it? Cell signaling. That steroids can pass through and they actually have their functions at the nucleus. Anyways, testosterone would go through the blood, through the basement membrane, and into the Sertoli cells where it binds with something known as ABP. And ABP stands for androgen binding protein. I hope I didn't lose you guys. Cholesterol, LH, cholesterol to testosterone. Testosterone binds with ABP. After that, FSH binds to Sertoli cells. And this will lead to three different steps. First step is the conversion of testosterone into estradiol by an enzyme known as aromatase. Okay? Step 1, testosterone to estradiol by aromatase. Step 2 is release of inhibin, which has a negative feedback on FSH. Okay? Of course, there has to be a negative feedback mechanism, and this is done by the release of inhibin. Inhibin would go all the way through the blood to the anterior pituitary. It would tell it to stop producing FSH. And step 3 is the secretion of testosterone plus androgen binding protein into the lumen of the seminiferous tubule. And then it will lead to the piling up and concentration of testosterone in the seminiferous tubules. And something we should know is that testosterone is needed for the maturation of sperm. Okay? Now, something unrelated, but it's still part of this lecture, is that in the fetus, the hypothalamic pituitary gonadal axis is underdeveloped. And therefore, we don't have LH production or FSH production. On the other hand, placental HCG acts in place of LH and it stimulates steroidogenesis. If you guys remember, we said that we need the production of testosterone in the beginning so that we have the male reproductive organs. So HCG stimulates the testes, and then the produced testosterone leads to the development of the male reproductive organs. Internal organs by testosterone, external organs by DHT, which is a product of testosterone. Now let's look at the duct system. First of all, we have the epididymis. Epididymis, specifically the head, has ciliary movement plus muscle contraction plus flow of fluid, and all of this would lead to the movement of sperm. We also have microvilli in the epididymis which absorb testicular fluid and they pass the nutrients to the sperm so that it develops and thrives, okay? And then we have non-motile sperm which becomes motile in the 20 days which it spends in the epididymis We mentioned this before. And lastly, during emission, contraction of the epididymis expels the sperm into the vas deferens. Deferens, it's an S over here, okay? Now, the vas deferens propels sperm from the epididymis. Technically not though. The vas deferens is connected to the epididymis and sperms move all the way from the epididymis through the vas deferens and finally into the urethra. Clinical correlation over here is that men with cystic fibrosis have normal spermatogenesis. However, they have azoospermia, which is no sperm in the ejaculate. The reason is they have congenital bilateral absence of vas deferens. Very important, remember this. Congenital bilateral absence of the vas deferens. So the sperm would be produced, however, it will not go to the ejaculate. Now let's talk about some very important secretions of the male accessory glands. The first secretions are given by the seminal vesicles. They produce fructose, which is used for glycolysis by the sperm. They also produce coagulating enzyme, which groups up sperms from the name coagulating, coagulation. And they also produce prostaglandins, which stimulate the wall of the uterus. And a very important number over here is that 70% of the volume of semen is produced by the seminal vesicles, okay? Then we have the prostate. The prostate would secrete citrate and enzymes such as fibrinolysin, and fibrinolysin liquefies the coagulated semen 15 to 30 minutes after ejaculation. 10% of the volume of semen is produced by the prostate, and the secretion of the prostate activates sperms. And finally, we have bulbourethral, also known as Cowper's glands, and they produce thick, clear mucus, which neutralizes acidic urine in the urethra. Normally, you shouldn't have urine. However, in case you have urine in the urethra when there is emission and ejaculation, it must be neutralized by the secretions of the Cowper's glands. And now let's talk about the molecular mechanism of a male erection. It's very simple, looks complicated. Don't worry about it, very simple. Let's go step by step. Firstly, emotions, thoughts, sensory input, and even penis mechanoreceptors may send a signal. It doesn't matter, okay? This signal then leads the nerve to release nitric oxide. From here, you guys should know this from cell signaling again. Nitric oxide would activate guanylyl cyclase. Guanylyl cyclase would change GTP to cyclic GMP. And then cyclic GMP would cause, when it increases, it would decrease intracellular calcium. This decrease in calcium would lead to smooth muscle relaxation of the arteries. This is also known as vasodilation. After vasodilation occurs, the corpora cavernosa becomes engorged with blood. And this blood would lead to the compression of the thin-walled veins, and therefore the blood would remain stuck in the corpora cavernosa. Now, this trapped blood causes enlargement, rigidity, and elongation of the penis in an erect position. And this is known as a male erection. Okay? Now, there's a clinical correlation we should mention, which is over here. To end an erection, cyclic GMP must be changed to GMP, and this is done by type 5 phosphodiesterase. If we want to sustain an erection for a longer period of time, then we could technically just inhibit this enzyme. So this is actually the mechanism by which Viagra acts. Viagra is a type 5 phosphodiesterase inhibitor, and it inhibits the conversion of cyclic GMP to GMP. Therefore, cyclic GMP would lead to all of this. And lastly, for this slide, erection is parasympathetic, meanwhile emission is sympathetic. Let's talk about emission and ejaculation for the last slide of this lecture. Emission is the movement of the sperm and associated fluids from the epididymis to the urethra. And the doctor had this in the slides. I'll just add it for completion's sake. This is the process by which emission actually occurs. Now, ejaculation is the expulsion of the semen from the penile urethra. They work after emission takes place first and then followed by ejaculation. And again, this is the process by which ejaculation takes place. You may pause the video if you want to read it. This is it for lecture 1. Now let's continue with lecture 2 of male physio, which is testosterone, biochemistry, function, and abnormalities. Starting with androgens. Androgens are sex steroids. They're synthesized from cholesterol. They're poorly soluble in plasma, and therefore they attach to something known as sex hormone binding globulin, which is produced in the liver. And it's very similar to androgen binding globulin. They have literally the same function. However, one is produced in the liver, one is produced in Sertoli cells, and yeah, they have different names. And lastly, androgens bind to intracellular receptors and affect transcription. You guys know this already. Some androgens we should know is testosterone, DHT, which is dihydrotestosterone, androstenedione, and DHEA. I'm not going to read this. Please remember all of them. Now, the order of potency. Potency simply means how strong they are. If they're strong, they're going to have a stronger effect. The most potent one is DHT, followed by testosterone, and followed by the others, androstenedione and DHEA. Now, testosterone is primarily responsible for primary sex characteristics and secondary sex characteristics. Testosterone is also used, testosterone is also converted to estradiol, which is an estrogen, in adipose tissue by the enzyme aromatase. We already spoke about aromatase before, and it's also found in adipose tissue, and it converts testosterone to estradiol. This is relevant because of number one, testosterone increases bone growth. After that, it gets changed to estradiol, and then estradiol shuts down bone growth. The doctor mentioned this example a couple of times. I thought it was high yield. Another example is in obese individuals, obese males specifically, you would have something known as gynecomastia, which is growth of the breast tissue. And this is because they have more adipose tissue, therefore more testosterone would be converted to estradiol, and therefore they would develop some female secondary sex characteristics, such as growth of the breast tissue. And finally, some functions of testosterone in the fetus is that it's used for the development of male internal genitalia. Functions of testosterone in puberty and adulthood is virilization, anabolic effects such as increased muscle mass, and spermatogenesis. Now let's talk about sex hormone binding globulin in details. SHBG binds androgens with a greater affinity than estrogens. This is very important. And only the free hormone is bioactive. By free hormone, we're talking about either androgens or estrogens, okay? So the androgen, which is binding to the sex hormone binding globulin, would not be bioactive. It would not have an effect. However, the free hormone, which is not bound to the sex hormone binding globulin, would have an effect in the body, no matter where the location is. Now, in the event we have increased SHBG, we would have increased estrogen effects. Because think about it like this. Increased SHBG means we have more SHBG. This increase in SHBG would bind to testosterone, would bind to androgens with a greater affinity, and they would leave out the estrogens. And therefore, the ratio of estrogens to androgens would increase, and therefore, we would have increased estrogen effects. A clinical effect of this would be gynecomastia in men, again, because you have increased estrogen effects, so you would have secondary sex characteristics of females present in men. Some causes of this would be increased estrogens and hyperthyroidism. Now let's talk about decreased sex hormone binding globulin. When we have decreased levels of sex hormone binding globulin, this would mean we have less androgens bound to the sex hormone binding globulin, and we would have an androgenic effect. And this would show as hirsutism in women. Okay? And some of the causes are increased androgens, of course, increased androgen effect, hypothyroidism, and nephrotic syndrome. With nephrotic syndrome, you have you have increased filtration of sex hormone binding globulin, and therefore decreased sex hormone binding globulin. Now, the result of either of these is estrogen and estrogen or androgen amplification, respectively. Okay. Something which I had no idea where to add. It's quite important though. Gonadotropin releasing hormone increases in infancy. Okay. And the effect of this is that it determines maleness or femaleness. The doctor mentioned this by saying maleness is uh, basically the kids being risk takers and like basically having a strong personality. Meanwhile, femaleness is being shy. Whatever. That's what he said. And after it increases in infancy, it would drop, stay on the low, and then it would increase in pre-puberty, and we know what happens after that. Now let's look at the hypothalamus pituitary gonadal axis, HPG axis. In the beginning, we would have signals from the brain centers, and then they would send the signal to the hypothalamus. After that, the hypothalamus would release GnRH in a pulsatile manner. Remember this, in a pulsatile manner. This GnRH would act on the anterior pituitary and they would release FSH and LH. Now, I want you guys to pause and answer this question. Which cells would FSH act on and which cells would LH act on? 3, 2, 1. FSH would act on Sertoli cells and LH would act on Leydig cells. LH, Leydig. Okay, good job. After that, the testes, specifically the Leydig cells, would produce testosterone. Okay? And testosterone would then have its effects in the body. This testosterone would also have negative feedback on the anterior pituitary, specifically on LH production. So testosterone would tell the anterior pituitary stop producing LH. It would also go to the hypothalamus and tell it to stop producing GnRH. And it would go to the brain centers and tell it to stop triggering the hypothalamus. Okay? On the other hand, FSH would bind to the Sertoli cells and then they would release inhibin. Inhibin would specifically go to the anterior pituitary and specifically have a negative feedback on FSH, not LH. Okay? So, one more time, testosterone has a negative feedback on the anterior pituitary on LH production. It has a negative feedback on the hypothalamus on GnRH production and negative feedback on the brain centers on stimulation of the hypothalamus. On the other hand, um, inhibin, which is a product of FSH binding to the Sertoli cells, would have a negative feedback on the anterior pituitary on FSH production. Some other things we need to mention is that leptin would stimulate the brain centers to send a signal to the hypothalamus. We also have some other substances we should know of: beta endorphin, interleukin 1, prolactin, GABA, and dopamine. Prolactin and GABA have inhibitory effects. Okay, you should know that prolactin and GABA have inhibitory effects on the brain centers. Okay, we mentioned that. Now, I told you guys to remember 5-alpha reductase. It came back to us. So, 5-alpha reductase converts testosterone to DHT. And we have two types of 5-alpha reductase. The first type is type 1, and it stimulates sebaceous gland activity and is linked to acne in puberty. Remember this, acne in puberty, very high yield. Type 2 stimulates the growth of the prostate, the growth of the penis, pubic and axillary hair, facial and body hair, and it increases muscle mass, everything else basically. And a clinical relevance over here is that finasteride is a 5-alpha reductase 2, type 2, inhibitor, and it's used clinically to treat prostatic hypertrophy. Because one of the functions of 5-alpha reductase 2 is the stimulation of growth of the prostate. If we want to stop the growth of the prostate, we should inhibit it. Okay? Remember this. Now, let's talk about clinical disorders of testosterone. The first one is 5-alpha reductase deficiency. We also have CAIS, complete androgen insensitivity syndrome. Now, I want you guys to go all the way back to when we were discussing the fetus and testosterone producing the male internal, whatever. Okay? And we will go back to that diagram, but I want you guys to think of these effects happening in the beginning, not in a grown-up. So with 5-alpha reductase deficiency, you would not have the 5-alpha reductase enzyme, and therefore, even though you can produce testosterone, you will not have its conversion to DHT. So the deficiency would be in DHT. And if we don't have DHT, as you guys can remember, DHT is important for the development of the male external genitalia. No DHT means we don't have male external genitalia being developed. And as we said before, the default is female. And so we will have female external genitalia in those patients. Now, testosterone is produced normally, so we would have male internal duct system, epididymis, vas deferens, and seminal vesicles. However, we would have female or ambiguous external genitalia. Ambiguous simply means something in between male and female. Now, they're often raised as females and they virilize at puberty. Lab findings would show normal or high testosterone, low or absent DHT, and an increased testosterone to DHT ratio. The second condition is CAIS, complete androgen insensitivity syndrome. It's quite severe, and it's because there is a mutation in the androgen receptor gene. So bear with me. You have a mutation in the androgen receptor gene, and therefore you would not have an androgen receptor, or you would have a faulty one. For the sake of discussion, let's say that you will not have an androgen receptor, okay? So the pathophysiology is that testosterone and DHT, both of them are produced, but the target tissues are completely resistant to their effects. So let's go all the way back. I want to explain it in that particular diagram. So we said there is no testosterone or there's no androgen receptor at all. So the testes would produce AMH. It would inhibit Mullerian duct formation. We would not have a uterus. This is good for males, right? The testes would also produce testosterone. Normally, it should stimulate the Wolffian duct to form the male internal duct. However, we mentioned that there is no androgen receptors. And so we would not have Wolffian duct proliferation, and so we would not have a male internal duct too. So no female internal duct, no male internal duct, no internal duct at all. And then testosterone would be converted to DHT. DHT would try to act on the genital tubercle, your genital folds, blah, 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 to form the male external genitalia. However, there is no receptor. One more time, there is no receptor, and therefore the external genitalia will develop into the female external genitalia because female is default. And that is basically it for this condition. Let's go back. So in these patients, there would be 46 chromosomes XY individual with female external genitalia, a short blind ending vagina because there is no internal duct system at all, absent uterus due to normal AMH, undescended testes because we mentioned before that the testes need testosterone signal to descend. If the testes does not have testosterone receptors, it's not going to be able to detect the testosterone and it will not descend. And the testes are often found in the labia or inguinal canals, and this is not the proper location, and if they're not removed, they would become cancerous. Primary amenorrhea is a common presentation. Lab findings show high testosterone and LH due to lack of negative feedback because there is no receptor in the pituitary gland, and so there would continuously be high LH. Okay. Now there's one more clinical disorder, and this is unlike these two. This would be in grown-ups. Okay. These are from the beginning in the fetus. This would develop when the patient takes androgenic steroids. So I think we all know this. Athletes, males or female, sometimes take androgenic steroids to enhance their performance. In the case it's a male, this is the pathway. So exogenous testosterone would lead to negative feedback and it would inhibit the hypothalamic pituitary gonadal axis. This would lead to decreased intratesticular testosterone. The testis would produce less testosterone because there's less LH and FSH. And then the function of intratesticular testosterone is very unique. It's different from exogenous testosterone. And it has a trophic effect on the testes. It would lead the testes to grow and increase in size, okay? If there's decreased intertesticular testosterone, there would be decreased testicular size. And since the testes is smaller, you would have less cells involved in spermatogenesis, and there would be a decreased sperm count. If women abuse androgenic steroids, they may present with virilization. Now, let's talk about CAH, which is congenital adrenal hyperplasia. This is basically a deficiency of 21 hydroxylase, and therefore all the precursors would be shunted into the androgen synthesis pathway. The presentation in females is more severe than in males. In 4 to 6 XX females, they would present with virilization of the external genitalia. You would have clitoromegaly and labial fusion. You can imagine it in a way that the female genitalia is somewhat transitioning to male genitalia, scrotum-like, because of the increased androgens, okay? However, in males, they would present with precoccus puberty, which simply means early development of pubic hair and phallus growth. Now let's talk about hypergonadism. Hypergonadism is excess androgens in childhood, and this causes precoccus puberty. Types of precoccus puberty are central or GnRH dependent precoccus puberty, and the cause for most of them is unknown, idiopathic. The second type is peripheral or GnRH independent precoccus puberty, and a cause of it we just mentioned is CAH and Leydig cell tumors. Peripheral means an issue with the testes. Central means an issue with either the hypothalamus or the pituitary, or something in between, if there isn't. Okay. And then hypogonadism is a deficiency in androgens, which is caused either by, number one, disorders of the HPG axis, specifically the HP, the hypothalamus and the pituitary, not the gonads. And this would be known as hypogonadotropic or secondary hypogonadism. Doctor also mentions this term with this, so it would be hypogonadotropic hypogonadism. The second type is testicular dysfunction, and it's also known as hypergonadotropic or primary hypogonadism. And the doctor mentions this term with this term, so it would be hypergonadotropic hypogonadism. Let's explain it in this image. So this would be a normal individual. You would have the hypothalamus secreting GnRH, stimulating the anterior pituitary to release LH and FSH. The LH and FSH would stimulate the testes to produce testosterone, and you would have negative feedback. All the hormones are in normal levels. In primary hypogonadism, you would have a failure of the testes. Primary is failure of the testes. Secondary is failure of either the pituitary or the hypothalamus. Anyways, in primary hypogonadism, um, you would have no, the beginning would be normal GnRH production and then normal LH and FSH. However, since the testes are not responding, you would have no negative feedback and there would be increased GnRH production, increased LH and FSH production, the gonadotropins, and therefore it's known as hypergonadotropic or primary hypogonadism. So, quick recap: hypogonadism because there's decreased testosterone, and hypergonadotropic because there is increased LH and FSH. And an example of testicular dysfunction, a syndrome with testicular dysfunction, is Klinefelter syndrome. And in Klinefelter syndrome, you have fibrosed testes. Now let's look at secondary hypogonadism or hypogonadotropic hypogonadism. And it's a disorder of either the hypothalamus or the pituitary. A specific example is Kalman syndrome. And in Kalman syndrome, you have a disorder with the neurons of the hypothalamus. So you would have decreased GnRH and therefore decreased stimulation of the pituitary and then decreased LH and FSH production. And even though the testes are normal, since you have decreased LH and FSH, there is decreased testosterone release. Therefore, it's hypogonadotropic hypogonadism. Quick recap: Klinefelter syndrome. It's 47XXY. And a quick tip for you guys is the moment you see a Y in the genotype, it's immediately a male, no matter the number of X chromosomes you see. In Klinefelter syndrome, patients have testicular atrophy and they show female secondary sex characteristics such as gynecomastia in males. They would also have wide hips, etc. Secondary sex characteristics, okay? Their testes would be fibrosed, and therefore there is no functioning cells, and therefore there is no inhibin and testosterone released, and therefore there is no negative feedback on FSH and LH. And finally, this would mean that there is excess gonadotropins, and it's a hypergonadotropic hypogonadism syndrome. Now, Kalman syndrome, we mentioned that it's a failure of the GnRH neurons to migrate from the olfactory bulb, and the lack of the GnRH neurons is in the hypothalamus. So it's an issue with the hypothalamus. Patients present with hypogonadotropic hypogonadism, decreased LH and FSH, decreased testosterone, anosmia, which means lack of smell, because the neurons fail to migrate from the olfactory bulb. It's an issue with the olfactory bulb. Anosmia and cryptorchidism, because there is decreased testosterone secretion. The testes fail to descend. There would be normal Wolffian duct differentiation because of placental HCG. Even though LH is not being produced, we have placental HCG in the beginning, and therefore there would be normal Wolffian duct differentiation, okay? And finally, if you give exogenous GnRH, the pituitary would respond and it would produce LH and FSH, okay? And this is how you diagnose, I think. I know for sure that this is how you would treat Kalman syndrome patients. Then we have CAIS, quick revision, we already mentioned it. Patients would have a female phenotype, female external genitalia, and female secondary sex characteristics. However, their genotype is completely male, 46XY. They would have blind ending vagina, and the testes are located in the abdomen with no internal structures, no female or no male internal structures at all. In the partial condition, not complete, partial AIS, the patients may present with ambiguous genitalia and gynecomastia. And finally, we have two hypothalamic pituitary lesions. The first one is prolactinoma, second one is craniopharyngioma. In prolactinoma, the mechanism, prolactinoma simply means a prolactin secreting tumor. Okay? So its tumor is going to secrete so much prolactin. And this prolactin would inhibit GnRH release. We mentioned this before in our table, our diagram, I mean. Basically, prolactin will inhibit GnRH release. And the presentation is hypogonadism, which is low libido, erectile dysfunction, infertility, galactorrhea, and if the tumor is very large, you would have visual field defects. And you also have craniopharyngioma. Both of these are hypo, okay? Hypogonadotropic, hypogonadism. Now for lecture 7, hormonal control of spermatogenesis. You guys should know this by now. Took it in F&D, took it in high school, blah, blah, blah. This is meiosis, okay? This is meiosis 1, which would split the chromosomes. And then this is meiosis 2, which would split the chromatids. If it occurs perfectly like this is known as disjunction, okay? Disjunction. This is normal. Let's look at example B. You have an error with the splitting of the chromosomes. One cell takes all the chromosomes, the other cell does not take any chromosome. And this is non-disjunction in meiosis 1. Let's look at the last example, example C. You have the cell undergoing meiosis 1, which is normal because the chromosomes has been split. And then in meiosis 2, let's look at the pink cell first. In meiosis 2, the chromatids have split perfectly. This is disjunction. However, in this cell, one cell took all the chromatids, the other cell did not take any, and this is known as non-disjunction. Okay? In meiosis 2. Example C is non-disjunction in meiosis 2. Example B is non-disjunction in meiosis 1. And example A is disjunction. About 60% of spontaneous abortions are due to aneuploidy. Aneuploidy simply means an incorrect number of chromosomes in a cell, okay? Examples of conditions are trisomy 21, Down syndrome, Klinefelter syndrome, which has 47XXY. You have an extra X chromosome. And Turner syndrome, which is 45 chromosomes, X, and there's a loss of Y, okay? So it's 45X0. Now let's talk about spermatogenesis. It's there's too many details in this image. You're not required to know most of them. Whatever I say is important, okay? So in the beginning, you have spermatogonium placed in the basal compartment during embryogenesis, okay? In the beginning. Spermatogonium are placed there and they remain there. Now, the spermatogonium would undergo mitosis. One spermatogonium will remain over here, and the other one would go through the tight junction into the adluminal compartment, okay? And once it goes, it's now known as a primary spermatocyte. Don't worry about the ploidy and the number of chromatids, okay? It's not important. Once it goes through, it's now known as a primary spermatocyte, okay? And then it continues to divide. It's now known as the secondary spermatocyte, divides for the last time through meiosis 2, and it's now a spermatid, a round spermatid. And this round spermatid undergoes spermiogenesis to become a sperm-like looking spermatid or a mature spermatozoa, okay? Let's go over it one more time. In this diagram, you have spermatogonium over here, and then this spermatogonium will divide. It's going to give us two cells, the type A daughter cell and type B daughter cell. The type A daughter cell will remain in the basal compartment and it will divide in the future, giving us more sperms, okay? It's going to remain over here. The type B daughter cell, on the other hand, will move across the tight junction and it will leave the basal compartment. It will move into the adluminal compartment and it's going to continue dividing. Meiosis 1 will transform it from primary spermatocyte to secondary spermatocytes. And then when it goes under meiosis 2, it's going to form the early spermatids, the round spermatids. And the spermatids are gonna undergo spermiogenesis, and they will give us mature spermatozoa or sperm looking like spermatozoa, spermatids. Okay. Now let's take a more detailed look into spermiogenesis. What happens in spermiogenesis exactly is number one, there's condensation of the nuclear material. Then there is formation of the acrosome, this part of the head, which contains enzymes. Then there's repositioning of spermatid to allow formation and elongation of the tail. Let's take a look in this image. As you can see, these spermatids are positioned in a way to allow the fluid to push the tails in this direction, and therefore it's going to lead to growth and formation of the tails, okay? And there's also mitochondrial spiral formation. You can appreciate it in this image. And finally, there is removal of extra cytoplasm, okay? You would start from this round-looking cell and just look at the amount of cytoplasm present in the sperm. It's very little. If you have more cytoplasm, the sperm would die due to oxidative stress. Don't worry about that. I'm just mentioning it, okay? Now let's look into spermiation. First of all, you have non-motile spermatozoa, which are released by the sertoli cells into the lumen. Once they're released into the lumen, they move by epididymis contraction. They do not move by tail movement because the sperms remain inactive in the male due to a process known as decapacitation. However, when they enter the female, they must activate and they activate through capacitation. Okay? Now, decapacitation leaves the sperm inactive and therefore the sperm cannot fertilize. This is important because we don't want the sperm to waste its energy in the male reproductive tract. Now, decapacitation depends on sperm surface associated proteins that are controlled by the interaction between cholesterol, phospholipids, and fibronectin-like substances. Capacitation, on the other hand, leaves the sperm active and the sperm can fertilize. This happens in the female reproductive tract. Sperm capacitation takes around 4 to 6 hours in the female reproductive tract. Changes that take place in the sperm. Number one, change in membrane fluidity due to removal of cholesterol from the sperm membrane. Number two, removal of glycoproteins from the membrane that blocks sperm binding to the egg. Number three, a change in membrane potential that permit calcium entry and facilitate acrosome reaction. A clinical case that we should remember and know, I think the doctor is going to question you on this, is Y chromosome microdeletions in the AZF region, okay? Y chromosome microdeletions in the AZF region. Just remember this. AZF region is found in the Y chromosome. And this is the most common genetic cause of spermatogenic failure. It would result in either azospermia or severe oligospermia. Azospermia simply means no sperm in the ejaculate. Severe oligospermia is decreased sperm count. We will talk about it in sperm defects. And this is just some patho. Varicocele, we mentioned that before in anatomy. Cryptorchidism, we mentioned that before in anatomy. You can read it if you want. They both lead to either azospermia or oligospermia. Chemotherapy leads to damage to spermatogonia. That's what you should know. Chemotherapy leads to damage to spermatogonia, and this may lead to azospermia. Now, mumps orchitis is an infection, and if the infection spreads all the way down to the testes, you would have testicular atrophy and azospermia. Another review table, you can pause and read this on your own. What I predict the doctor might question you on is that the duration of spermatogenesis is 64 to 72 days long. And the clinical correlate for this is that after vasectomy, you need to wait for 3 months to ensure that there is no sperm in the male reproductive tract at all. Okay. Another high yield thing which I mentioned before is Y chromosome microdeletions, which take place in the AZF region. I think the doctor will get you a question on this. And lastly, CFTR mutations. We mentioned this before, cystic fibrosis, and we will mention it again. It leads to congenital bilateral absence of the vas deferens or agenesis of vas deferens. Now for the last lecture by Awad and your last male physio lecture, infertility and sperm defects. This lecture was a bunch of memorization. I honestly don't think you should memorize everything. I wouldn't if I was in your place. Anyways, doctor had all of these um like data and stuff. I don't think you should memorize this. From this page, what's very important is this definition, the WHO definition of infertility, which is a disease of the reproductive system defined by the failure to achieve a clinical pregnancy after 12 to 24 months of regular unprotected sexual intercourse. One important thing as well, not related to this slide, is that a normal acrosome, remember we said the acrosome is where the enzymes are stored in the head of the sperm. The normal acrosome should take around 40 to 70% of the head. More than that is abnormal, less than that is abnormal. Now let's talk about some sperm abnormalities. The first one is oligospermia. You guys should know this by now. And it simply means a low sperm count of less than 15 million less than 15 million sperm per milliliter. Second definition is azoospermia, which means there's no sperm in the ejaculate. And the next one is globosospermia. The way I remember it is globe, round. And it simply means the sperm has a round head. And finally, sperm macrocephaly syndrome. And macro means larger, cephaly, head. Therefore, the head is larger than normal. Some things that could lead to abnormalities. The first one is reduced acrosome reaction. Remember, we said the enzymes of the sperm are present in the acrosome. The sperm would then go to meet the egg, and it should release those enzymes to go through the wall and release its genetic contents into the egg. That would be a complete fertilization. If you have a reduced acrosome reaction, this would lead to an abnormal sperm. The second factor is increased temperature. We mentioned this so many times in the PAL. I got bored of it, honestly. Anyways, increased temperature would um, would basically damage the Sertoli cells and spermatogenesis will not take place. This will leave us with azoospermia in severe cases or oligospermia. The doctor mentioned an example of medicine students having a fever and this decreasing their sperm count. And then testicular cancer. In cases of testicular cancer, you have a higher chance of producing abnormal sperms like globospermia and sperm macrocephaly syndrome. And finally, with varicocele, the blood piling up would heat up the testes, and just like with cryptorchidism, spermatogenesis will not take place. This will leave us with oligospermia and in severe cases, azoospermia. Now let's talk about thermotaxis versus chemotaxis. Thermotaxis is basically using temperature, is basically the sperm using temperature to search for the egg. Chemotaxis is the sperm using chemicals, and the chemical it uses is progesterone, and it uses chemicals to find the egg. The way thermotaxis works is that the sperm is produced in the scrotum. The temperature is 3 degrees lower than the body temperature. When the sperm is released into the vagina, the sperm is going to follow the body's temperature. The temperature would gradually increase. It's going to follow this temperature gradient all the way to the egg. Now, the question is the egg in the right or in the left fallopian tube? And this is where chemotaxis kicks in. Once the sperm gets over here, it's going to start following progesterone, which is released by the egg, which is a chemical and a hormone, and it's basically going to follow it all the way and it's going to fertilize the egg. Thermotaxis is temperature, chemotaxis is by progesterone or chemicals. Now, this is a revision table. We already mentioned Kalman syndrome, and the defect would lead to azoospermia. Something you should note with Kalman syndrome is anosmia. Very, very high yield anosmia. The moment you see anosmia, immediately choose Kalman syndrome. Then you have Klinefelter syndrome. A keyword with Klinefelter syndrome is small, firm testes because the testes have been fibrosed. Um, the doctor said, don't worry about this. You have cystic fibrosis, CFTR mutation. This is the third time we're mentioning this. It's very high yield. And it leads to congenital bilateral absence of vas deferens, which leads to azoospermia. And it's often associated with mild pulmonary disease because it's cystic fibrosis. The stuff I have underlined are keywords you should underlined in blue are keywords you should look for in the exam, okay? And then we have Cartagner syndrome. And Cartagner syndrome is very unique. It basically results in immotile sperm due to a dying protein deficiency. I'll mention it one more time. In Cartagner syndrome, you have immotile sperm due to dying protein deficiency. And other features is you would have a right-facing heart, also known as situs inversus. And you would also have bronchiectasis. Again, it's a pulmonary issue. Mainly focus on this situs inversus. A normal heart would be facing the left, and situs inversus would be a right-facing heart. I think this is it for me. Good luck on your exam. I wish you the best, and Awad out.
All right, guys. Now back to female physiology. Now, before we continue with this, it's great that you've continued so far with the crash course, and I would like you guys to pause for some time, drink some water, and maybe do some jumping jacks or push-ups just to refresh your mind, and then come back to this. All right? This is the last phase of our crash course, and inshallah, you'll be done with ERP with this. All right? Now let's start. Bismillah. Okay, so first let's talk about the HPO axis, which is the hypothalamus, pituitary, and ovarian axis. I hope you guys are not fed up with all my diagrams. All right, let's start. So first of all, for this axis, if you know the axis really well, all your questions, you can get them right. Just know this axis and it'll be fine, inshallah. So we have the hypothalamus that releases the gonadotropin releasing hormone or GnRH. Now, this hormone is in a constant level during childhood. But when puberty is supposed to start, the GnRH levels peak and drop, which is called a pulsatile manner. Now, because of the pulsatile release of GnRH, this pulsatile release only can stimulate the anterior pituitary to release two other hormones called the luteinizing hormone or LH and follicular stimulating hormone or FSH. Now, depending on how fast or slow the GnRH pulses are, you can get either LH or FSH. Now, if there are lots of pulses or faster pulse, it's luteinizing hormone that's released, and if there are fewer pulse or slow pulse, the FSH is released. All right. Now, this luteinizing hormone and FSH will then go and act on the ovaries. This ovaries will then release three different hormones. We have the estrogen, a type of estrogen which is the estradiol, and then it releases progesterone and it releases inhibin. All right. Yeah. Now, estrogen is the one that's responsible for all of the sexual characteristics, for development of the follicles, and so on. Progesterone is responsible for maintaining pregnancy and placenta growth, and inhibin it practically inhibits. Now let's move on to the feedback. All of these hormones are the end products. If there's enough end products, we don't need the stimulation anymore. So all of these end products go and inhibit both the hypothalamus and the pituitary, especially for inhibin. Inhibin inhibits only and only FSH, all right? It does not inhibit anything else. It goes and inhibits GnRH and thus inhibits FSH. Okay, so it's released, it's related to decreasing FSH levels. Now, one important thing that I want to mention is what happens during middle of the cycle of middle menstrual cycle. When the cycle is in the middle and you were expecting ovulation and you want LH surge or this LH to peak, in that case, only estrogen or estradiol will go and activate both the hypothalamus and the pituitary, and this is the one that leads to LH surge. All right, so only only positive feedback happens during mid-cycle, just before ovulation. All right. Now, these are not the only hormones which are playing a role in the sexual life of a female. The other hormones are coming from the androgens, the adrenal glands, and these are the androgens and the dihydroepiandrosterone, DHEA. Now, these androgens, or yeah, let's just call them androgens, go to the adipose tissue, peripheral adipose tissue, especially the white adipose tissue, and they're then converted to another type of estrogen, which is called as estrone. All right. So this estrone is coming from the peripheral adipose tissue. Compare that to estradiol, which is coming from the ovaries. All right. Again, if there is enough androgens, these again go and inhibit both the hypothalamus and the pituitary. Okay, that was all about the HPO axis, and whatever I said is written over here. One important thing that we need to know is that this is the what do you call, potency of each androgens. Just read through it; it's all fine. Okay. Now, that was some of the feedback mechanisms for controlling the release of sex hormones. But that's not the only thing. About the hypothalamus, which we thought was the big boss, there are many other mechanisms and hormones that control the release of GnRH. Now, the main important thing that I want you to know is kisspeptin. Kisspeptin is a peptide hormone that is usually sleeping in childhood. So it has no role in childhood, and because of this, GnRH is continuously in a constant level. But when kisspeptin starts to get up, it leads to activation of the pulsatile generator of GnRH. All right. So this kisspeptin only starts during puberty. Okay. The second thing that I want to talk about is prolactin. So prolactin is the one that is released during lactation, or when the mother is breastfeeding. This leads to inhibition of GnRH pulsatility, or GnRH in general, which leads to decreased production of LH, FSH, and estrogen, and thus there is no periods, or this leads to amenorrhea, and this is called as lactational amenorrhea. That's prolactin. What about CRH? CRH is corticosterone releasing hormone, and this increases during stress. So when a person is extremely stressed, do they want to reproduce? No. So this again leads to inhibition of GnRH, and thus decreased production of any of the sex steroids. Moving on to endorphins. Endorphins are released during exercise or sometimes even during stress. Okay, so if someone's exercising excessively, all right, this leads to abnormal increased levels of endorphins, and this inhibits again the GnRH release, and thus inhibits sex steroids production, and thus they will have no periods. All right. The last thing that I want to talk about is leptin. So leptin is something that is released from the adipose tissue. Now, when a person is obese, okay, or for example, when a child is obese, they tend to have puberty at an earlier age. Okay, why? Because the leptin goes and activates kisspeptin, and the kisspeptin then kicks off the pulsatile GnRH release. All right, compare that to a person who is starving. When a person is starving, they do not have enough adipose tissue, and their main focus is to survive. So they do not have leptin, and they do not have any kisspeptin that is activated, and therefore there is no GnRH pulsatility and no periods. All right. Okay, now moving on to the different archees that are mentioned in this lecture. The first milestone that is reached in the sexual cycle of a female is something called as adrenarche. So adrenarche is when the adrenal glands starts increasing its release of dihydroepiandrosterone and androgens. All right, so these levels increase. Now, what is the role of androgens and dihydroepiandrosterone? Is that they're responsible for the pubic hair. They're responsible for increasing the secretion from both the sebaceous glands and sweat glands. They're responsible for axillary hair, etc. All right, so when these increase, when adrenarche kicks in and these androgens increase, this leads to what you call pubarche, which is the which is the formation of pubic hair. All right. Now, normally in a person, adrenarche first comes, and then pubarche, and then we move on to the third phase, in which the kisspeptin kicks the pulsatile nature of GnRH, and then this leads to the production of LH and FSH. And then estrogen kicks in, and then you have the estrogen that makes the breast formation or thelarche, and also the periods that start, which is menarche. All right. Now, moving on to all of the hormones in different stages of a person's life. All right. So again, I want you to answer this with me, but I won't pause. Just think it in your head. All right. Now, during childhood, what happens to the kisspeptin? The kisspeptin is sleeping, and because of this, the GnRH is constantly high. And if the GnRH is constantly high, what happens to LH and FSH? They're low, and low levels of LH and FSH leads to low estrogen. And if there's low estrogen, what happens with androgen? Anyways, androgen and estrogen are not related, all right? This androgen, if there is adrenarche, it leads to high levels of androgens, okay? But for now, in childhood, it's normal. Pre-puberty is a stage when adrenarche kicks in, okay? But still, the kiss peptin is sleeping, and because of that, the GnRH is normal or constantly high. This leads to low LH-FSH and low estrogen. And again, as I mentioned, the adrenarche kicks in over here, and this leads to increased androgen. Puberty kicks in when the kiss peptin awakes, okay? And this gets up. And then the GnRH also has a pulsatile nature, and this again increases the LH-FSH levels, and this leads to increased estrogen. And then also we have the adrenarche that's still continuing, and then androgen levels are also high. Now, some of the abnormality that can happen is when there's not enough kisspeptin, or kisspeptin does not wake up in time. This leads to delayed puberty, or when there's less estrogen, or when this again leads to delayed puberty. Now, androgens, if there's increased androgens, again, as I mentioned, this leads to increased facial hair, which is called hirsutism. Yeah, that's basically it. Now, thyroid hormones and leptin, again, can also, if there's low thyroid hormones or low leptin because of starvation, this leads to delayed puberty. And also, if there's high leptin, this leads to precoitus puberty, or, yeah, early puberty. Now, the next thing is Tanner staging. Tanner staging, there are 5 different stages, all right? And the breast development and the pubic hair. Now, breast development is denoted with B, and the pubic hair is denoted with P. There are 5 stages. The first stage is pre-adolescent, where nothing is there, they look normal. And then the second stage is when a small bud or breast bud develops, and there's fine hair in the pubic area. Third phase is when there's coarse hair or curly hair. Fourth stage is when there's a bigger mound, and again the hair growth continues. And the fifth stage is the adult type, all right? Now, normally you expect the pubic hair and the breast development to be linked together and in the same stage. This is the normal development. But sometimes the pubic hair develops more than the breast development. Why? This happens when there is low levels of estrogen. And low levels of estrogen is happening because of the delayed puberty, all right? So if the pubic hair is more than the breast development, the person is having delayed puberty. Compare that to a person who's having maybe this type of breast development but a pubic hair like this. Okay, this happens because there is early estrogen or increased estrogen because of precoitus puberty, early puberty. The adrenal glands are all normal. They're developing fine. However, the estrogen is the one that is increased now. All right. Okay, now moving on to hormonal patterns in perimenopause and menopause levels. So perimenopause is just before menopause, and in this case there is an ovulation happening. So there is sometimes egg is released, sometimes egg is not released, and so on. However, the kisspeptin levels are still. Oh wait, what's going on? Okay. Anyways, never mind, guys. The kisspeptin levels are still normal, okay? And this leads to pulsatile generation of GnRH, and there's increased LH and FSH. However, because the ovulation is happening sometimes and not sometimes, the estrogen levels are dropping, all right? And this leads to some of the what you call symptoms like hot flashes and so on. But again, not that much severe. And then there's normal androgen levels as well. Compare that to menopause. In menopause, the kisspeptin levels they're still normally high, and the GnRH levels are pulsating. However, they become high, and the LH and FSH become really, really high. Why? Because in menopause, the ovary is depleted or wiped clean from any follicles. Okay, so there is nothing going on, and there's no release of estrogen. So the estrogen levels decrease really, really low. And when there is low estrogen levels, there is no feedback inhibition for both the hypothalamus and the pituitary. And that is why there's increased levels of both GnRH and LH and FSH. Then moving on to androgens, they're normal as usual. Now, this was what happens in menopause. If the menopause happens earlier than normal, we call them as premature ovarian insufficiency, in which there is increased depletion of ovarian follicles. All right. Now that wraps the first lecture. Moving on to the second lecture. Now, the second lecture, we're talking about 2 important processes. We have the folliculogenesis and the oogenesis. Now, in folliculogenesis, we have the follicles that are developing, again, under the influence of FSH. So first half of the folliculogenesis until here, FSH works. And then after here, after ovulation, you have the LH that works. Now, what happens when FSH is working? When FSH is working, the primordial follicles, which everyone is born with, some of them are stimulated to become the primary follicles. And the primary follicles then grow to become secondary follicles, and then the tertiary or antral follicles, and they grow because to become the Graafian follicles. Now, these follicles have what you call the follicular cells, which are divided into two types. We have the theca cells, which are on the outside, and we have the granular cells, granulosa cells, which are on the inside. Now, the theca cells and the granulosa cells together in this phase, they release estrogen, all right? And this is the part of ovary that releases estrogen. But you also have another cells in the middle, which is these random spaces that you have, which have stromal cells. And the stromal cells over here release androgens, all right? Now, other hormones that are released from the ovary is something called as anti-Mullerian hormone. Okay, I'll talk about this in details later on, but just keep in mind that this is also released. After ovulation from the Graafian follicle, we have the LH that is working now. Now, the LH that is working makes sure that the corpus luteum is alive, and also the corpus luteum now is releasing progesterone. All right. So we have the estrogen that is released during the pre-ovulatory stage, and the progesterone that is getting released after the ovulatory stage. Yes, that's basically it for folliculogenesis. Now, for oogenesis, that is what happens to the egg itself. Now, these were all what was happening to the cells surrounding the egg. Now, the egg or the oocyte inside the primordial follicle, during birth, it is paused or arrested in the prophase 1 of meiosis 1, all right? And that is what happens, that is the stage of the oocyte until ovulation. Just before ovulation, the oocyte completes its meiosis fully, the first meiosis, so meiosis 1 is done, and then it gets arrested at that stage also, all right? And then we have, yeah, that's basically oogenesis. All right. Now moving on to the hormones, as I mentioned before, the ovary also releases inhibin, right? Now there are two types of inhibins that we need to know: inhibin B and inhibin A. During the follicular stage of follicular phase of yeah, follicular phase of ovarian cycle, which is this phase, there is a release of inhibin B from the small antral follicles. Again, what does it function? They inhibit FSH release. Compare that to inhibin A, which is released from the corpus luteum in the luteal phase, and again, they inhibit FSH levels. Now, moving on to the functions of anti-Mullerian hormone. Anti-Mullerian hormone are released from the follicular cells during the follicular phase, and they prevent overstimulation and preserve egg reserve. For example, if there is no anti-Mullerian hormone, thousands of eggs will be recruited every cycle, and this will lead to early depletion of the ovarian reserve. We do not want this to happen, and that is why anti-Mullerian hormone is released from the follicles. This growing follicles will make sure that there is no more recruitment of primordial follicles, and only one Graafian follicle is released every month. Okay, now moving on to the release of the production of estrogen and progesterone. This is important, guys, okay? Now, we mentioned that there are two layers of cells from the follicles, which are the theca cells, and which are on top, and the granulosa cells. Now, the theca cells have LH receptors, and the granulosa cells have FSH receptors. Now, before ovulation, what is the one that is released? We have the FSH that is released, but also you have LH that is there. Now, the LH goes and attaches on its receptor and activates cyclic AMP, which makes the conversion of cholesterol to androstenedione, which is a type of androgen. Just know that, okay? Now, this androstenedione that moves on to granulosa cell. Why does it move to granulosa cell? Is because only the granulosa cell has the aromatase enzyme for converting androstenedione to estrogen. Okay, so the estrogen that is coming from the ovary has to be made from two cells. Okay, the theca cells, which convert cholesterol to androstenedione, and then the androstenedione goes to granulosa cell and is converted to estrogen by aromatase. Again, the granulosa cell is activated by FSH. All right. Now, if there's a problem in follicular stimulating hormone or FSH, what happens is that there is no follicle development. Okay, so FSH is responsible for follicles to develop. That's one thing. And if the follicles are not developing, that means there is no egg that is made. And if there's no egg that is made, and there is no there is no preparation for the pregnancy itself, this leads to amenorrhea, or there's no periods. All right, and also this leads to increased androgens. Why? Because in granulosa cell you need to stimulate the granulosa cell for converting this androgen or androstenedione to estrogen. If there is no conversion, then all of this androgen piles up, and this leads to increased androgens. All right, this happens before ovulation. What happens after ovulation? After ovulation, we have the corpus luteum. The corpus luteum is something that is formed because of again, eating up fat, you could say, okay? So there's fat stored inside, and we call them as theca lutein cells and granulosa lutein cells, all right? Now, the cells over here just change their names. However, the function is the same. What happens in theca cells? Again, LH attaches, it converts cholesterol to androstenedione. Androstenedione moves on to granulosa cell. Granulosa cell that is stimulated by FSH then converts androstenedione to estrogen, okay? But another thing is that this granulosa lutein cell of the corpus luteum is also affected by luteinizing hormone or LH, and this converts cholesterol to progesterone. So this is the main pathway that happens in the granulosa cell after ovulation, which is in the corpus luteum. All right. So if there's a problem in luteinizing hormone, then there is no ovulation. Why? Because again, we need luteinizing hormone for LH surge. That is one thing. The second thing is that the luteinizing hormone, if it is low, it leads to low progesterone. Why? Because luteinizing hormone is the one that is responsible for converting cholesterol in granulosa cell to progesterone. All right. Okay. Now moving on to androgen problems. Okay, so we talked about androgens and they're released from the adrenal gland and they're released from the ovary stromal cells. All right. If there is a problem in either the adrenal gland or the ovary, there is a problem in androgens. Or if there is a problem in sex hormone binding globulin, again, this is a protein that makes sure that it is binding to androgen and making androgen not work. If there's low binding globulin, there's increased free androgen and therefore more active androgen. Or if someone is taking external steroids. So whatever leads to increased androgens, this leads to the following diseases. Okay, it leads to polycystic ovarian syndrome. Okay, and this leads to insulin resistance. And again, what are the effects of androgen? Excess of hair, hirsutism, acne, balding or loss of hair, and clitoromegaly, which is the increased size of clitoris. Okay, so moving on to the estrogen, what is the function of estrogen? Before moving on to that, estrogen is released from three places. We have the ovary in the form of estradiol, which is the most potent form of estrogen. Then we have from the peripheral conversion of testosterone to estrogen, which is in the form of estrone in the fat cells. And then the other one is in the placenta, which is the estriol, all right? So these are the three forms of estrogen. Whatever the form of estrogen is, what is their function? They're responsible for the formation of breasts and the female fat distribution, and also for the formation of external genitalia. Now, they're also responsible for making the follicles to grow and also for the endometrial to proliferate. Endometrium in the sense, yeah, increased size, all right, and also increases the myometrial excitability and makes sure that when this again happens during periods. Okay, when someone has menstruation, this and estrogen makes sure that the myometrium contracts. Now, the upregulation of estrogen, luteinizing hormone, is the one responsible for um, what do you call the ovulation. All right, but estrogen also makes sure that the receptors for estrogen, luteinizing hormone, progesterone also increases. Okay, so what increases the receptors? Estrogen. All right, and also we mentioned that the feedback inhibition and so on. All right, now another thing is the effects of estrogen on bone. Okay, so estrogen is the one that's responsible for bone health in females. If there's low estrogen, this leads to osteoporosis and also liver and cardiovascular health. Another thing is what its effects in cervix. In the cervix, it leads to alkaline mucus that is watery and sticky. Again, whatever it does is make sure that the sperm is easy to enter and it sticks easily and enters inside. Okay, this is called spin barkate effect, which is just shows that the cervix mucus is sticky during this time in the follicular phase. All right, because of the effect of estrogen. And then it also has furning, which is a leaf-like pattern. If you leave the cervical mucus to dry, it shows that. Just know that. Okay, again, because of estrogen. So this is in the follicular phase because the estrogen is high during follicular phase, and then lowers the vaginal pH. Now, if there is deficiency of estrogen in the early period during childhood, this leads to low breast development. There is no external genitalia, and practically this leads to delayed puberty. All right, but normally there is low estrogen during menopause, as I mentioned before. If there is excess estrogen, this leads to all of the other what you call problems. For example, this leads to excess endometrial thickening. All right, this leads to increased risk of cancer like the endometrial cancer, cervical cancer, breast cancer, and so on. And also this leads to increased clotting problems like which are called as thromboembolic events. All right, anyways, I'll teach this way. So what happens to progesterone when progesterone is what's the function of progesterone? So progesterone, as we mentioned, it is released from corpus luteum, right? And corpus luteum during the first few parts of the luteal phase, it is kept alive by luteinizing hormone. When pregnancy kicks in, it is kept alive by human chorionic gonadotropin. Just keep that in mind. Progesterone is everything that is related to pregnancy and makes sure that the pregnancy is all right. So it maintains the endometrium, decreases contractility of the uterus, and prevents its contraction. All right. Now, one important thing that I want you to keep in mind is that progesterone increases the body temperature. All right, increases the body temperature. So when there is increased progesterone during the luteal phase, the body temperature is naturally high. All right, and also it thickens the cervical mucus and prevents sperm from entering because you already have, you know, ovulation that's already happened. Now you do not want any other sperms to come, okay? Whether it's fertilized or not fertilized, you just don't want sperms to come, all right? That is the function of progesterone. And also, it happens to increase the growth of breast, both the lobules and alveoli. Now, again, only the gland grows, but there is no release of milk, okay? Just the gland is the one that grows. Okay. All right, let's move on to the menstrual cycle lecture. So this lecture is basically all about menstrual cycle, all right? Now, the menstrual cycle has two parallel running cycles. One cycle happens in the ovary and the other one happens in the endometrium. Now, in the ovary, what happens is that these follicles are the ones that are developing, and then you have ovulation, and then you have the corpus luteum, all right? Now, for ovulation to happen, as I mentioned before, you need to have increased LH, okay? And increased LH, and also you need to have increased estrogen. So first you have the follicles that are developing because of the follicular stimulating hormone, so you can see there's a rise. And then when ovulation needs to happen, you have estrogen that peaks up and luteinizing hormone that peaks up. Now, when the luteinizing hormone peaks up, three important mechanisms lead to ovulation. First is that the luteinizing hormone increases um, progesterone levels, okay? It starts increasing progesterone levels a bit. And this progesterone levels go and activate collagenase. Collagenase is something that weakens the wall of this follicle. That's one thing. Second thing is that it leads to inflammatory cytokines like prostaglandins, leukotrienes, and so on to be created inside this follicle. And again, this leads to activation of lysozymes, which again weaken the wall and also lead to leakage of fluid inside this follicle. Now, when the fluid leaks inside, which is called plasma transfusion, the pressure inside increases. Now, the pressure inside, along with the weakened wall, pushes the ovum or the egg outside, and this leads to ovulation. All right, this happens mid-cycle. After that, we have the corpus luteum that survives for about 14 days only. So if you have the menstruation that happens or the bleeding that happens at a particular day, you count 14 days backward, and that is the day of ovulation, all right? Because the corpus luteum just survives for 14 days. And yeah, that's basically it for the ovarian cycle. Now, moving on to the endometrial cycle. The endometrial cycle has three different parts. We have the menstrual part, we have the proliferative part, and the secretory part. Now, the estrogen that is produced from the follicles makes sure that the gland is growing, all right? But the progesterone that is released from the corpus luteum makes sure there's increased blood vessels that are growing inside the already grown gland, all right? This is important for us to know. Okay, so estrogen is responsible for the proliferation or the thickening of the gland, and progesterone is responsible for the blood vessels and so on. Okay, did I mention all of this? Yeah, basically that's it. Oh yes, one important thing is when there is increased progesterone and estrogen that is released from corpus luteum, this leads to feedback inhibition to the hypothalamus and pituitary, and that is why there's lowered levels of LH. Now, when LH levels drop below a certain point, this leads to dying of corpus luteum, and that's why it becomes the corpus albicans. All right. Again, this is an important slide, guys. The questions in the exam ask you about the different graphs of LH, FSH, and so on. So they just give you a graph and ask you what graph this is, okay? So just pause here and just, like revise by yourself, because whatever I explained is what's over here. Just, again, keep the graphs in mind. Okay, so basically, first day to 14th day in the ovarian cycle is the follicular phase, and it's stimulated by FSH. The FSH stimulates the follicular cells to release estrogen. This estrogen is the one that is responsible for the proliferative phase of the endometrium, which is the growth of the endometrium. After ovulation, from the 14th to the 28th day, you have the luteal phase, and this is made responsible by luteinizing hormone. The luteinizing hormone acts on the corpus luteum, which secretes mainly progesterone, which is responsible for the secretory phase of the endometrium, and this makes sure that there's increased blood vessels. Now, moving on to some of the disorders, okay? Just just going over this real quick, something we have is amenorrhea. Amenorrhea are of two types, which is amenorrhea is basically there's no periods. Primary amenorrhea happens in kids who never ever had periods, okay? So they just did not ever have periods because they never started. This happens because of a deficiency in sex steroids, and there again, all of the mechanisms that I talked about before, anything that leads to an abnormal pituitary gland disorders or ovarian disorders, etc., can lead to, again, primary amenorrhea. Secondary amenorrhea is when the period started, but again, they stopped for a long period of time. This happens in pregnancy because, again, in pregnancy, you don't want periods to be happening. Lactation because of the increased prolactin, or after menopause, or when a person is excessively exercising, starvation, and so on. Again, what I mentioned before. Oligomenorrhea, it's when there's irregular periods, and dysmenorrhea is when there's painful periods, okay? Now, what I want you to remember, especially for dysmenorrhea, is primary dysmenorrhea, where there is no problem in the uterus, and the only issue is this increased prostaglandins or inflammatory stuff, and this leads to painful spasms of the uterus, and this is the cause of pain. The secondary dysmenorrhea is when there's an actual problem in the pelvis or the uterus, which leads to pain. Then moving on to menorrhagia. Menorrhagia is when there is excessive bleeding. As I mentioned before, excessive bleeding happens if there is increased thickness of the uterus endometrium. And uterus endometrium is what you call made thick because of estrogen. So if this increased estrogen, this increased bleeding, and this is called menorrhagia. Now, one important thing, again, keep in mind is anovulation. When there is no release of egg. Again, for ovulation, what do you need? You need both the LH surge and the estrogen. Anything that's decreasing either the estrogen or the LH surge leads to an ovulation, all right? But there is still bleeding or menstruation happening because the endometrial cycle is normal. Only the ovarian cycle is affected over here. And as I mentioned, PCOS. So if someone asks you what is the hormone that is affected in PCOS, the first thing that you talk about is LH, okay? There is increased LH, and this increased LH is the one that causes havoc and increases androgen levels as well, okay? And there's no ovulation in PCOS. Now, quickly touching upon contraceptives because it was mentioned. So, contraceptives are usually when you give estrogen or progesterone. Again, the increased estrogen and progesterone leads to feedback inhibition of FSH and LH, and this leads to no LH surge. And also, the progesterone makes sure the thick mucus is thick, and again, makes sure that there is environment is hostile for sperms to enter, and so on. Again, you can give them together or only progesterone. There's something else called morning pill or postcoital pill, which has high doses of estrogen, prostaglandins. Again, the estrogen and prostaglandins are responsible for contracting the uterus. So whatever's, even if there was fertilization that takes place, no implantation happens. All right. Okay. Now, I want you to by yourself reply to all of these questions that I'm going to ask. All right, guys. Bismillah. Now, what increases body temperatures? As I mentioned before, the increase in body temperature is because of progesterone. What causes the furning pattern of the cervical mucus? Again, this is during the follicular phase, and this happens because of estrogen. What causes the GnRH pulsatility to kick in? It is kisspeptin. What about ovulation? Again, the two important hormones is LH and estrogen. What increases cervical cancer risk if it is abnormally high? Again, this is estrogen. All right. The answers are written over here. Now, okay, this is one important thing. In developing follicles, what is the one that stimulates developing follicles? It is FSH. Now, what do developing follicles release? They release estrogen. What about corpus luteum? Corpus luteum is kept alive by LH. What do corpus luteum release? They release progesterone. If there is no ovulation, what is the cause of no ovulation? Again, increased LH is the cause of no ovulation. What does it lead to? It leads to infertility. All right. What is menorrhagia? Again, the cause is again increased estrogen, and this leads to excessive bleeding, which is the menorrhagia. Hirsutism or increased hair in the facial area is again caused by androgens, and hot flashes, which happens during menopause. Hot flashes and all of the other symptoms again happen because of low estrogen. And leptin, which is a fat hormone, if it is high, it leads to precoitus puberty. If it is low, it leads to delayed puberty. Okay? Now, this is the summary of all of the diseases. Okay, so if there's precoitus puberty or early puberty, this happens because of anything that I mentioned in the slide that has all of the kisspeptin and all of that, right? Anything that increases the effect or activity of GnRH or FSH will lead to precoitus puberty. The opposite is for delayed puberty. Tamam? Anything that leads to lower GnRH or lower FSH leads to delayed puberty. Primary amenorrhea is when there's no periods from the beginning. This happens because of decreased estrogen, decreased FSH/LH. Again, yeah, this is the thing. Menopause is normal, and this is again when there's low estrogen, low progesterone. Again, there is low feedback inhibition, which increases FSH/LH. PCOS, again, the main cause is increased LH. Again, this increased LH will lead to increased androgens, and this leads to anovulation. What is the cause of osteoporosis in females? Again, this is low estrogen. Menorrhagia, again, I mentioned this before. Secondary amenorrhea happens because of increased prolactin or pregnancy and low sex hormones. Again, this is anovulation, and primary dysmenorrhea, as I mentioned, is because of prostaglandins. All right, now moving on to the second last lecture, which is pregnancy, hormonal control, and physiological changes. Now, let's start with fertilization and how it all happens. So first, when the sperm enters the uterus, it undergoes something called as capacitation. And capacitation is nothing but just maturation, all right? And once the sperm comes near the egg, what happens is something called as acrosome reaction happens. Now, acrosome reaction is something that is important to catalyze or start activate the enzymes in the cap of the sperm itself. All right. So how this happens is that on the head of the sperm, you have something called this ZP3 or zona pellucida 3 binding protein, okay, which is a protein. This protein now binds to zona pellucida and then activates the reaction inside in the enzymes over here. Now these enzymes, we have one important enzyme called as acrosin, all right? Now, acrosome reaction has an enzyme called acrosin. Now, this acrosin is the one that now starts digesting all of these zona pellucida layer over here. As you can see, the granules over here are digesting the zona pellucida, and now the nucleus membrane or the cell membrane itself is in direct contact with the egg. And then there is another binding protein called as oocyte binding protein on the head of this nucleus that is just bare right now. And then this oocyte binding protein binds with the oocyte and enters into the cytoplasm. All right. And then once it enters into the cytoplasm, the nucleus of the sperm and the nucleus of the egg fuse, and this is called fertilization. And again, before it fuses, the oocyte itself completes its second meiotic division. Again, the first meiotic division was finished when? It was finished back in ovulation. All right. Now the second meiotic division is getting completed once the sperm enters into the oocyte cytoplasm. This is fertilization. After that, we have something called as cortical reaction. This is when the oocyte itself starts secreting some enzymes into this small space called as perivitellin space. These granules are the ones that make the zona pellucida harder or thicker, preventing any further sperms from entering into and fertilizing the oocyte, practically preventing polyspermy, all right? And then what happens is that the fertilized zygote starts dividing. And once it starts dividing, it becomes the morula, which is many cells, and then it becomes the blastocele, and then the blastocele becomes a blastocyst, and it just moves along the fallopian tube. Now, around the sixth day, then is where the blastocyst starts implanting. Now, how does implantation happen? There are four important steps that we need to know. First is the hatching. So, all the while that the the zygote is traveling and becomes the morula and the blastocyst and so on, it has this coating of zona pellucida still, okay, again, to prevent polyspermy. And then once it wants to come and attach into this placenta, it undergoes something called as hatching. And hatching is when it gets rid of the zona pellucida layer and now it's free and is ready to hatch. Now, there is something that can go wrong in this hatching stage. This is when there is early hatching. For example, if there is hatching in this hatching happens in this part, then that means the zygote is ready to implant over here itself. And if implants over here, this leads to ectopic pregnancy, which is what we don't want, all right? So if there's a problem in hatching, this leads to ectopic pregnancy. After hatching happens and it comes near the actual endometrium, after traveling through the fallopian tube, what happens is that opposition happens. Opposition is when the inner cell mass, which is the blue cells over here, the inner cell mass are directly facing the endometrium, all right? Why? Because this is the direct connection that it should have so that the inner cell mass starts growing as a baby. Okay, so this is why the inner cell mass is now facing or opposing the endometrium. It's called apposition, all right? Again, for apposition to happen correctly, we have something called as leukemia inhibitory factor. This leukemia inhibitory factor is, again, important for apposition. If there's a problem with leukemia inhibitory factor, there's a problem with apposition, and there's a problem with implantation. All right. And then the next stage is adhesion. Now, adhesion is where there is proper connection between the what do you call this as? Yeah, between the zygote or the blastocele or blastocyst and the endometrium itself. And this happens by integrins, all right? The integrins on the blastocele itself is called as embryonic integrins and no, trophoblastic integrins, which is TIN, sorry, the trophoblastic integrins, which is TIN, and on the endometrium, it's called as endometrial integrins, all right? So this is TIN and EIN, and these both get attached and lock themselves, and this is called adhesion. After adhesion, we have invasion. Now, invasion is when now, trophoblastic cells are of two layers, you know that, right? So we have cytotrophoblast and the syncytiotropoblast. Now, the syncytiotropoblast releases enzymes that digest this endometrial layer, and then this allows the entire blastocysts now into the wall of the endometrium, and this is the complete implantation, all right? And also another function of the syncytiotropoblast is that it releases human chorionic gonadotropin. Important to remember that also. Okay. Now, moving on to placentation itself. So that was implantation. After implantation, you wanted the endometrium to turn into a placenta, right? How does this happen? One important part of that is decidualization, okay? This is where the uterine part, or the part of the placenta that is in the part of the facing the mother, undergoes certain changes leading to the formation of placenta. Again, this happens because of the effect of progesterone, HCG, which is human chorionic gonadotropin, interleukin 11 or IL-11, again, the leukemia factor, and prostaglandins, all right? Just keep this at the back of your mind. And another important thing is the spiral artery remodeling, okay? Now, spiral arteries are the arteries that supply the endometrium. Usually, they're like this, thin and really curved, okay? This is when there's no pregnancy. However, when you're having pregnancy, when the person is having pregnancy, this spiral arteries, the cells in the wall of the spiral arteries start breaking down, okay? Now, when they start breaking down, usually you expect there to be hemorrhage or bleeding, right? But there's no bleeding. Why? Because the cells surrounding these spiral arteries, which are the trophoblastic cells, start covering up whatever space has been made to make it like lakes, okay? Which are the lacuna, all right? So the spiral artery now breaks down, and the pool of blood is gathered by the trophoblasts that surround them, all right? And this is very important. Why? Because when the baby is growing or the fetus is growing, it does not want blood to come in such a force. It wants it to be in a nice flow, and that is why you have blood pooling up over here. Now, what happens if this does not happen properly? What if spiral artery is not remodeled properly and this is an abnormal pregnancy? What happens is that now the pressure remains high in across the mother and the fetal circulation, all right? And this again increases pressure in the mother's blood as well, which leads to something called as preeclampsia and eclampsia. So preeclampsia and eclampsia is abnormal hypertension in the mother, which can lead to even seizures, okay? So this is really bad, right? And this happens because of spiral artery problem in spiral artery remodeling. Now, moving on to the hormones secreted by the placenta themselves. First, we have is the HCG or human chorionic gonadotropin. Again, HCG is secreted by the placenta. But what are its effects? Now, HCG, usually the luteinizing hormone, is the one that makes the corpus luteum alive. Once the luteinizing hormone decreases levels, the HCG takes over. Okay, so now the HCG's job to keep the corpus luteum alive. Now, in the corpus luteum, you have two different types of cells, okay? You have the thecal lutein cells, and the HCG acts on the thecal lutein cells to make androgens, okay? Which is what the corpus luteum was doing usually, okay? But before it was being stimulated by luteinizing hormone, now the difference is that HCG is the one that is stimulating it. After that, we have the granulosa lutein cells in the corpus luteum, which make now estrogen and loads of progesterone, which is the one that's responsible for maintaining pregnancy. Again, before the corpus luteum, when the luteinizing hormone was happening, was working on corpus luteum, the same hormones were the ones that were being secreted by the granular lutein cells. Another very important and unique function of the human chorionic gonadotropin is that it goes to the fetus itself, and if it's a male fetus, it goes to the Leydig cells and stimulates it to secrete testosterone. All right. Okay, now the pregnancy test that is usually done is by testing the urine for human chorionic gonadotropin. All right. Now, the levels of human chorionic or HCG actually increases. Okay, so this is the week of pregnancy. Now, in this 0 to 5 weeks, you have what you call the luteinizing hormone. So not 5 weeks. This is supposed to be oh yeah, 5 weeks. Actually, no. This is about 5 to 10 to 12 weeks. All right. Now, when there's about 0 to 10 weeks, about approximately this period, the luteinizing hormone is the one that's acting. After that, you have the human chorionic gonadotropin acting. Okay, so this levels increases. Slowly, during the end of pregnancy, human chorionic gonadotropin decreases. Okay, why this happens is because now the placenta is taking over. So as I mentioned, the placenta is taking over the production of progesterone over here. So progesterone is now not needed anymore from the corpus luteum. So the corpus luteum, we don't need to keep the corpus luteum alive, and so human chorionic gonadotropin decreases. All right. Now, if anything happens to human chorionic gonadotropin levels before the placenta takes over, this leads to decreased production of or survival of corpus luteum, which leads to death and termination of the pregnancy itself. Okay, again, this is before the 12 weeks or 7 to 9th week before the luteal placenta shift happens. If there's any problem to the human chorionic gonadotropin before that, pregnancy terminates. All right. Okay, now let's move on to estrogen. Now, the main estrogen form that is secreted by the placenta is estriol, all right? Now, what is the function of estriol? Is that it increases placenta blood flow, okay, because again, you want that to happen to increase, to help the baby grow, and also increases progesterone receptors on the uterus itself, all right? And also it leads to mammogenesis, which is the growth of mammary glands and the glands, and then it also stops ovulation because the increased estrogen goes to the mother and inhibits the FSH and LH by negative feedback. And again, this stops ovulation so that we don't have any extra pregnancies happening in middle of a pregnancy. All right. Now, one important thing is to note is that how is the estrogen itself produced from the placenta? So it's not the placenta working on its own. From the mother, the placenta borrows the cholesterol, and from the cholesterol, it makes pregnenolone. Then this pregnenolone moves inside the fetus actually and is converted into dihydroepiandrosterone. Now, this dihydroepiandrosterone then comes to placenta and then it gets converted to estriol, and this estriol is the one that goes and acts on various sites and does all of its functions that's mentioned over here. All right, so this is important to know. Now, if there's any problem to the fetus, then there is no dihydroepiandrosterone made, and the levels of estriol, which is normally supposed to be made in pregnancy by the placenta, decreases. Why? Because there's a problem in fetus. All right. So levels of estriol is important as an indicator of the health of the fetus itself. Now, moving on to progesterone, which is again, as I mentioned before, after the placenta luteal shift, the progesterone is made by the placenta. So this is all made by the corpus luteum, and then placenta starts making the progesterone. Now, progesterone is important for destabilization, which is the conversion of uterine endometrium to the placenta, and also suppresses myometrial contractility because you want to maintain pregnancy, inhibits ovulation, again, by the same negative feedback, and also participates in mammogenesis and inhibits lactation. Very important is inhibits lactation. So when progesterone is high, it makes the breast grow and the glands grow. However, there is no production of milk, and this happens for the entirety of pregnancy. You don't want milk to be produced during pregnancy. You want it to happen after pregnancy, and progesterone levels decrease after pregnancy, which allows for lactation to happen. All right. Okay, now the next one is human placental lactogen. Now, human placental lactogen is very interesting because the levels, again, this is produced from the placenta itself, very interesting from the name itself. But human placental lactogen is in the levels increase as the placenta size increases. So if there's a good placenta and the placenta is working all good, then the placental HPL is also supposed to remain high. Okay, so if there's any problem to placenta, then the HPL levels become abnormal. All right. Now, the main function of a human placental lactogen is to ensure that the fetus is getting continuous glucose supply. Okay, but when a mother eats and the food goes into the stomach, the insulin immediately kicks in for the mother, right? And what does this insulin do? This insulin grabs this glucose and stores it inside in the fat. However, you do not want this to happen. When the person is pregnant, you want to make sure that the glucose is available for the fetus, and this is done by human placental lactogen. So human placental lactogen goes and inhibits insulin, so it causes insulin resistance in the mother and makes sure the glucose is all the time available in the blood for the fetus. So this is normal. Insulin resistance is normal, all right? To overcome this, what the mother does is that the mother's pancreas increases insulin production, okay? However, in certain cases, when the pancreas of the mother are not able to make enough insulin to overcome the effects of human placental lactogen, what happens is that gestational diabetes happen. So gestational diabetes is when there is excess amount of glucose circulating in the mother's blood, okay? Again, this is extra
over what the fetus actually needs. So HBL is secreted in excess to make sure that all the glucose that can be ever available is available to the fetus. But normally insulin is increased in production from the mother, and this overcomes the extra glucose. But when the pancreas of the mother is not able to make enough insulin, this leads to gestational diabetes. Gestational diabetes is when there's excess glucose in the mother's blood, and this leads to what you call hyperglycemia in the mother. Now, the same blood that in the mother is the one that's reaching the fetus, right? So this leads to fetal hyperglycemia as well. Now, the fetus is confused why there's so much glucose, and so it starts increasing insulin in the fetus itself. But the fetus needs increased glucose. Okay, so what happens is that when the little amount of glucose that's actually reaching the fetus is now getting stored, and this leads to fetal hypoglycemia, okay, and increased fat deposition. And with this increased fat deposition, the baby becomes fat, and this is called macrosomia, okay. And these are the effects of gestational diabetes. Just keep this in the back of your head. And moving on to the last lecture, guys. Come on, bravo, you guys came to the last lecture. Okay, now moving on to another set of hormones that are produced from the placenta, we have the oxytocin. Now, oxytocin is secreted from the posterior pituitary. Very important, posterior pituitary. Now, what happens is that this oxytocin shoots up only near parturition or labor. Okay, so what is parturition? Parturition is the process of giving birth, okay? And labor is the uterine contractions, all right? So oxytocin is the one that's responsible for the labor part of pregnancy, okay? Which is to push the baby outside. Now, how does oxytocin happen? So oxytocin is basically muscles to contract. And any muscles to contract, what do you need? You need calcium, right? And also the receptor of oxytocin is phospholipase C. So oxytocin attaches to the receptor, it activates phospholipase C, and then this opens the calcium channels, calcium comes in, and the muscles again, the whole cascade happens, and the muscles contract, all right? So this is basically something, just keep it at the back of your head. Another thing is Ferguson reflex. Now, Ferguson reflex just is how is oxytocin released? You don't want oxytocin to be released during this part of the pregnancy, right? Only during the end. And this happens when the baby is big enough and the head of the baby touches the cervix and starts stretching the cervix itself, okay? Now, this stretch goes and triggers a reflex, again, via nerves, to the posterior pituitary, which releases oxytocin. Now, the oxytocin then again makes the uterus contract. And when the uterus contracts, again, now the head of the baby is pushed even further into the cervix and making the cervix stretch even more. Again, this is entire cycle, and the cycle goes on until the baby is fully outside the mother's uterus, and again then that's when this cycle stops. Okay, this is called Ferguson reflex. Now, prolactin is another hormone that is produced from the anterior pituitary. Compare that to the oxytocin, which is produced from the posterior pituitary. Okay, now prolactin that is produced from the anterior pituitary is usually inhibited by dopamine in normal people. Okay, so they have increased dopamine and low prolactin. However, if there's a problem in the pituitary stalk that is connecting between pituitary stalk, which means there is no more connection or inhibition of dopamine, this leads to increased production of prolactin. All right, so prolactin increases, and this leads to galactoria. So normal person, just they're normal, however they're producing milk. This is because again there is loss of inhibition of dopamine on prolactin synthesis. Now, what happens in pregnancy is that the pregnancy, the one which stimulates prolactin synthesis is estrogen. Okay, and now prolactin has many functions. One function is to make mammogenesis. Mammogenesis is the again growth of glands and the breast practically, okay? But also another function that prolactin does is lactogenesis, which is the production of milk. Now, estrogen and progesterone is the one that prevent prolactin from secreting milk during pregnancy. You do not want that to happen. You want prolactin to make milk after pregnancy, but you want prolactin to work on the breasts and also increase the gland and other things during pregnancy, all right? So that's what happens. So after pregnancy, estrogen and progesterone levels drop. And once they drop, this leads to, again, automatic rise in prolactin hormones. Another thing is dopamine. Dopamine is still working in after pregnancy as well, right? So what happens is when the person is suckling, the baby, when it's suckling, this decreases dopamine, and that's when the baby is suckling and there's decrease in dopamine. Exactly when the baby wants to drink milk, that's when prolactin again works, and then it causes lactogenesis. Another important function of prolactin after pregnancy is that it inhibits ovulation, decreases GnRH. Again, we mentioned that before. Okay, so this is again a summary slide of all these hormones and what they do in pregnancy. All right, the heading is supposed to be something else, but anyways, so what happens to prostaglandins nearing labor? okay, when there's parturition, what happens to prostaglandins? They should increase, all right, because they again lead to contraction of the uterus. What about oxytocin? They increase. Oxytocin receptors on the uterus or the myometrium, they increase. What about estrogen? Nearing the end of or during labor, what happens to estrogen? Estrogen increases. Okay, what happens to progesterone? So we mentioned progesterone is the placenta, is the pregnancy hormone. So it maintains pregnancy, but now when you're ending when you're at the end of pregnancy or parturition, you do not want progesterone to be there. So progesterone decreases. What about progesterone binding protein? Interestingly, this will increase. Why? Because when you have increased progesterone binding protein, it binds to progesterone, prevents it from acting, all right? What about fetal cortisol? When there's during the part of labor, the fetal cortisol increases, which is basically, again, the fetus is getting stressed, you could say, and preparing for getting out into the real world, okay? Okay, now moving on to mammogenesis. What are the hormones that are responsible for mammogenesis or the production, not the production, the growth of the breast itself? So we have three hormones. We have the estrogen, progesterone, and prolactin, all right? What about lactogenesis, which is the production of milk? For this, we have prolactin. What about galactokinesis, which is the letdown of milk from the breasts outside, okay? This happens by oxytocin, very important, okay? This is because of oxytocin. Again, so oxytocin is not only for inducing labor, but also when the baby is suckling, it goes and has two different mechanisms. Okay, so when the baby suckles, the nerve impulses go to both the anterior pituitary and posterior pituitary. When it goes to the anterior pituitary, it releases prolactin. When it goes to the posterior pituitary, it releases oxytocin. And prolactin makes the milk form, and oxytocin makes the milk come outside. All right. Okay, so for suckling reflex and milk letdown, you need both the prolactin and oxytocin. If one works and the other doesn't work, there's an issue. For example, if there is no prolactin and only oxytocin, then maybe the muscles are contracting, but there's no milk coming outside. If there's only prolactin and oxytocin, the milk is there, but there is no contraction, and therefore the milk it's hard for the baby to suck it out. Okay. Okay, now there's something called Sheehan syndrome, which happens during labor, is when there is infarction or decreased blood to the pituitary gland itself. And this decreased blood to the pituitary gland will make the pituitary gland die, okay? And this leads to no lactation after pregnancy. Why? Because there is no prolactin, okay? However, there is oxytocin still released. Why? Because only the anterior pituitary dies. And then we have amenorrhea. Again, there is no production of FSH, LH, and so on. So there is no like no proper cycles, and also there's hypothyroidism because there is decreased thyroid stimulating hormone. Now, again, to summarize, just one thing, just keep it at the back of your head is that fetal hormones, some of the not some of the fetus, some hormones that fetus secretes. We have insulin, which is from the pancreas of the fetus, and then androgens from the adrenal glands of the fetus, and cortisol, right? Just these are some of the fetal hormones. And that's it, guys. Alhamdulillah, we're done. I hope and we hope this session was really useful for you guys. And if you have any questions at all, feel free to ask. We're more than happy to help you guys. And please scan this QR code for your feedback. And all the best for your exams. And inshallah khair, and you guys get the best of grades.